two, one. Please start, sir. We are live.
Yeah, so very good evening. Am I audible?
Yes, sir. Please go ahead.
Yes, yes. So very good evening, everyone. So after having a successful day one oncology next webinar yesterday on GI and GU cancers, today we'll be focusing on breast cancer and lung cancer. We have a lot of updates in the recent past published in ASCO and ESMO, and we'll be discussing three major abstracts, followed by some landmark discussions, and then role of testing in breast cancer. So without wasting much time, we'll move ahead. We already have Dr. Deepak Singh with us. So we'll be beginning with that abstract, and we'll be talking about Ascent-4 trial. So it's a phase 3 clinical trial investigating the use of sacituzumab govitecan and in combination with pembrolizumab for any previously untreated patients with metastatic or advanced triple negative breast cancer who are PD-L1 positive. So things are moving upfront with the combinations of IO and ADCs. So we'll begin through the data and see are we prepared for this or we have to wait for this. So with that, I invite Dr. Deepak Singla. He's a senior consultant in medical oncology and hematology at Indus International Hospital, Derabasi in Mohali. So over to you, sir. Uh, Dr. Deepak, are you there?
Avni, please call Deepak sir. No?
Yeah, good evening, everyone.
Hi, good evening, Dr. Kanika. I think if Deepak sir is not reachable, we can start with the first session.
Yes, sir. Yes, sir. Yes, sir. We can start from Kanika, ma'am. No?
Yeah, yes. So I think Dr. Kanika has already joined, so we can start itself with the first session, and then we will go according to the schedule. So after this introduction, I think to begin with the breast cancer session, we have Dr. Kanika Sharma with us. She is a senior consultant medical and hemato-oncologist, and she's currently working in Max Super Specialty Hospital, Mohali. So she'll be deliberating upon the Serena-6 trial. It's a very beautifully designed trial. It's a phase 3 trial of switching to camizestrants and while monitoring the liquid biopsy and if there are ESR1 mutations emergence. So we'll see how what the data speaks and how it can be utilized in our patient. So over to you, Dr. Kanika.
Yeah. Hi. Good evening, everyone. Sorry for the delay. And thank you for inviting me for this conference. So I'll be discussing the Serena-6 trial. My slides are visible?
Yes, ma'am. It is visible.
So I'll be discussing the Serena-6 trial, which is recently discussed in the ASCO 2025 meeting. That is the camizestrant plus CDK4/6 inhibitor for the treatment of ESR1 mutations during the first-line endocrine-based therapy ahead of disease progression. So just summarizing, giving a brief summary of the trial before discussing it in detail. So switching the aromatase inhibitor to camizestrant with continuation of CDK4/6 guided by the emergence of the ESR1 mutation during first-line treatment ahead of the disease progression, it significantly improved PFS. So this we have seen in the other studies also and in other subsites also like we do ctDNA monitoring. So to assess the early recurrence of the disease. So same way we can actually monitor the disease biology over the course of time and actually preempt the patients who are actually having an aggressive disease with the emergence of these mutations. So it is the first global registrational phase 3 study that demonstrated the clinical utility of ctDNA monitoring to detect and treat the emerging resistance in breast cancer. So that we'll be discussing. So giving a brief overview, like we have known the mechanism, testosterone is converted to estrogen peripherally in the presence of aromatase inhibitor, aromatase enzyme. And these aromatase inhibitor, it blocks these peripheral conversion, leading to the decrease in estrogen. So that these estrogen, they do not act on the estrogen receptors, leading to the cell proliferation. Whereas estrogen directly that is produced from the ovaries, they also acts, and so there are two mechanisms. So when we are giving AI and the disease progresses, we shift to fulvestrant, that is the receptor degradation. So that happens when there is an ESR1 mutation. So as we know that the ER positive subgroup of breast cancer, they are the most common, accounting for around 50 to 60% of the patients. So this is encoded by the ESR1 gene. So when there is an ESR1 mutation, it leads to a consecutive estrogen independent activation of these receptors. So they are actually rare at diagnosis, but when we start that, this is the standard first line treatment that we give, that is the CDK4/6 inhibitors with AI in the first line setting. So during this, the incidence, it increases from less than 5% to around 40% upon disease progression. So it is the next generation oral SERT, and it's a complete ER antagonist that was designed to inhibit this estrogen independent pathway. So it can be detected in the liquid biopsy prior to progression on AI plus CDK4/6. So in this open label PADA-1 trial, switching to fulvestrant plus palbociclib upon detection of ESR1 ahead of disease progression, it significantly improved the PFS upon versus continuing the AI and actually changing the therapy upon radiological progression. So in SERENA-2, this camizestrant significantly improved PFS versus fulvestrant. So based on this hypothesis that the fulvestrant is effective in ESR1 and camizestrant is beneficial than fulvestrant, so they created the SERENA-6, which tested the hypothesis that using camizestrant to treat that emergent ESR1 mutations ahead of these progression could actually extend the duration of benefit. So they have seen that ESR1 surveillance during the first line. So how many patients they actually developed this? So they have screened around 3,300 patients who were on first line AI plus CDK for more than around 6 months. And around surveillance, every 2 to 3 months testing was done. So in that, ESR1 mutation was detected in around 548 patients. Out of these, 315 were randomized. So 51, half of the patients, they were positive on first test. The remaining 40%, they were positive after 2 to 5 tests, and remaining 10% were positive after 5 tests. So they were tested using ctDNA levels using Guardant 360 study every 2 to 6 months. So coming to the background and the layoff of SERENA-6 study. So it's a phase 3 randomized double-blinded placebo-controlled study in which they have taken male or female patients with hormone-positive HER2-negative advanced breast cancer. All the patients, they have received AI plus CDK4/6. So all the three CDK4/6 were eligible as initial endocrine-based therapy for at least 6 months, because we know over the period of time, the chances of developing ESR1 mutation increases. And this mutation was detected in the ctDNA level in patients who have no evidence of disease progression. So in 1:1 randomization, these patients receive either the camizestrant, that is the 75 mg once a day, along with continuation of CDK4/6. Since it was a double-blinded, so placebo was given in both the arms. So the patient actually received 3 tablets, 1 for each. So they have further stratified into visceral versus non-visceral. ESR1 mutation detected on what level of testing, time from initiation of AI, whether within 18 months or more than 18 months, and what type of AI the patient have received. So based on these, they have a primary endpoint of progression-free survival and the secondary endpoint of PFS2, OS, safety, and what are the patient-reported outcomes. So when we see the statistical design of this study, so this planned enrollment, 300 patients were randomized, and primary analysis was planned after 195 PFS event, providing around 93% power to the study. When we talk about the interim analysis, it was planned after at least 135 PFS event, and all the patients have received at least one on-treatment tumor assessment. So p-value of less than 0.001 would be considered statistically significant using the Habertle-Peto boundary. So they have actually, the primary endpoint was PFS and the secondary was PFS2 and OS. So OS was immature at data cutoff and it was not discussed in the study. When we talk about the baseline characteristic, it was comparable between the two arms. The median age was 60 years with around 100% of the patients female population in camizestrant and 98% in the AI plus CDK4/6. And around 80% of the patients, they were of premenopausal status. At the time of ESR1 detection, again, as discussed, around half of them have at first and remaining of them, the patient they have at subsequent testing. So when we talk about the primary endpoint, that is the investigator-assessed PFS, the median PFS was 16 months in the camizestrant arm versus 9.2 in the AI plus CDK4/6, and the adjusted hazard ratio was 0.44. So we can see that there was early separation of the graph, and that kept on the separation was evident even on the further follow-up. So at 3 years also, there was separation, that is 30% versus 5.4% at 2 years, which is a significant difference that we can see. So when we
I'm
have...
sorry for intervening, need to conclude, please.
Sure. So when we have seen the investigator assessed in the forest plot, all the subgroup, they benefited with the addition of camizestrant as compared to the AI. When we talk about time to deterioration, again, there was a significant benefit with a camizestrant with an adjusted hazard ratio of 0.53. When we talk about the secondary endpoint, that was PFS2, it was also benefited with the hazard ratio of 0.52 with the addition of camizestrant. Talking about the safety profile, it was comparable. There was no new known safety, and as compared to AI plus CDK4/6, the most common is the bone marrow suppression, that is the neutropenia, anemia, and leukopenia that was seen. But it was manageable, and there was no more than grade 3 side effects that were seen. So concluding my study, switching AI to camizestrant with continuation of CDK4/6 guided by the emergence of ESR1 mutation during the first line ahead of disease progression, it significantly improved PFS in these patients. That was consistent across all the subgroups, and it delayed the time to deterioration in the quality of life versus upon waiting for the radiological progression and then changing the therapy. It is the first global phase 3 study to demonstrate the clinical utility of ctDNA monitoring in breast cancer. So it has the potential to become a new treatment strategy in oncology for the first-line patient out. Thank you so much.
Yeah, thank you, Dr. Kanika. Indeed, it's a very good strategy. But we also, am I audible?
Yes, yes.
Yeah, but we also need to look whether when we are switching to camizestrant on radiological progression, does that sequences matter, and will that lead to any overall survival differences or not? So anyway, it's a good thought for thought, and very important study to understand whether it can be applicable in our part of the world or not, because doing a ctDNA that frequently is still a distant dream as of now.
Sure.
So thank you so much.
Thank you.
So moving on, our next abstract is on breast cancer, and it's on triple negative breast cancer, and this is SN4 study, and this is about a phase 3 randomized controlled trial using a combination of ADC, that is sacituzumab govitecan plus pembrolizumab in the first line advanced or metastatic triple negative breast cancers. And for this, with us, we have Dr. Deepak Singh. He's a senior consultant in medical oncology and hematology at Indus International Hospital, Derabasi, Mohali. Over to you, sir.
Yeah, thank you so much, Dr. Ankit, for giving me this opportunity. And so the topic given to me is Ascent 04 Keynote D19 study. As we know, there is an unmet need to do more and more in the TNBC. This trial was conducted with Secretary Govindakan plus which is an ADC plus Pembro versus chemotherapy plus Pembro in patient with previously untreated PD-L1 positive advanced or metastatic triple TNBC. It's a phase 3 randomized trial. Next slide, please. So, what are the key takeaways from the ASCENT-04 Keynote D19 phase 3 study? There is an unmet need for the better treatment in the first line setting of patient with PDL positive metastatic TNBC. And Castellan, Govindakan plus Pembro led to the significantly, statistically significant and clinically meaningful improvement in PFS versus chemo versus Pembro. These results support the SG plus Pembro as a potential new first line option for the standard of care in the metastatic TNBC. Previously unmet need in previously untreated PD-L1 positive, locally advanced unresectable metastatic TNBC. Because the median PFS observed in the prior study in the chemotherapy in combination with the immune checkpoint inhibitors, it was a see the second line treatment. So rationale was because PROC2 is a surface protein which is found in the majority of the solid tumor. It demonstrated the overall survival benefit in the multiple phase 3 study. It approved for the second line metastatic TNBC and pre-treated hormone positive HER2 negative MBC in multiple
Dr. Deepak, your voice is breaking. Hello.
Yeah, now it's
You can,
am I audible?
yeah, you can switch off your video. That would help.
Sorry.
You can switch off your video. That would
Okay,
help.
I have switched. Next slide, please. Yeah. Coming to the ASCENT-04 Keynote study design. So the eligible candidates were previously untreated, locally advanced, unresectable, or metastatic triple-negative breast cancer patient with a PD-L1 positive with a CPS combined positive score of more than 10 or equivalent to 10 by a DECO method, and more than 6 months of since the treatment in the curative setting or prior anti PD-L1 was allowed, and it was randomization 1-to-1 in with the secukinumab Govindakan plus Pembro, which was given 10 mg per kg body weight on the day 1 and day 8, 21 days, plus Pembro, as we know that every 3 weekly, and total randomization of the patient was 221 versus the chemo plus Pembro. And the chemo arm was taken paclitaxel or nab-paclitaxel 100 milligram per meter square on day 1, day 8, and day 15, 28 cycle, or gemcitabine 1000 milligram per meter square plus carboplatin AUC2 on day 1 and day 8 or 21 day cycle plus Pembro. All treatment including SG or chemo was until the BICR verified disease progression or unacceptable toxicity. Endpoint was the PFS by BICR, and secondary endpoint was overall survival, overall response rate, duration of response, and safety and quality of life. Next slide, please. So statically analyzes more than 440 eligible patients to control the overall type 1 error. At primary analysis, PFS will be tested at one-sided alpha of 2.5%, and overall survival will be summarized descriptively at the time of primary PFS analysis. If the PFS is positive, a nominal alpha will be spent. If PFS is significantly at primary analysis, at the time of overall survival analysis, formal sequential testing of overall survival, overall response rate, and this treatment duration of physically functioning will be performed, and data cutoff was primary PFS of March 2025, and PFS by hierarchical testing procedure by intention to treat population. If the PFS by BSAR one-sided alpha is 2.5%, and overall survival nominal alpha spend if PFS positive. If no, the treatment stop. If yes, the overall survival and overall response rate by BSAR, yes. Then treatment of duration in physical functioning domain as measured by the EORTC C30. Next slide, please. So demographic and baseline characteristic coming to so majority of the patient, median age of the patient about 54 and 55 in the chemo pembro arm, and 65 years, more than 65 years, it was only only 26% in the both the arm, and majority of the them were white population, and all were in 38% were enrolled from the North America and from the West Europe, and the rest of the 62% from the rest of the world, and majority of them were 71% were having then the both the arms were having the eco performance status of 0, and 48% patients were having a recurrent disease after 12 months.
Hello, Deepak sir, we can't hear you.
Yeah. Next slide. Avani, can you move to the next slide, please? Yeah. So progression-free survival by the BICR, we can see that this curves are starting separating after the 2 months end of 20 months also. So median PFS was observed in the SG plus pembro arm, 11.2 months versus 7.8 months with a p-value of 0.001, and but 12 months PFS rate was seen in the 48% of the patient versus 33, and 6 months PFS was 72% versus 63%. Next slide, please. So by investigation, previous slide, please. So if we go to the subgroup, PFS by the investigator assessment also revealed the same. PFS was 11.3 months versus 8.3. After 1 year, 50% of the more than 50% of the around 50% of the
Hello, Deepak sir, we can't hear you.
patient.
I think some network issues at his end.
Yes, sir.
Dr. Deepak, can you hear us?
Yes, I can hear you. I switched to my mobile. So coming to the subgroup analysis. Yeah. Hello.
Yes, you are audible now.
Okay.
Please go on.
Am I audible now? Yes. Hello.
Yes, you are audible.
Am I audible? Okay. Coming to subgroup analysis. PFS observed.
Deepak sir, you have joined from two devices.
Okay. Right. Am I audible now?
Yes, sir, perfect.
So maximum PFS was seen. The patient who have received the PD-L1 neoadjuvant anti-PD-L1 therapy. It was seen 11.7 months, and the patient who are having the recurrence of disease after the 12 months of the remission, 16.6 months. Next slide. Slide. If we see the tumor response and duration of response by BSER, there is substantial longer duration of response and higher overall response rate, including an increased complete response was observed in the SG plus Pembro versus chemo plus Pembro arm. Complete
Sir,
response was
sorry for intervene. Need to conclude, please, sir, as we are running short of time now.
okay. Compared to the chemo Pembro, it was only 8%. And partial slide, please. Ascent Keynote D19 is the first efficacy of safety of an ADC plus checkpoint inhibitor in combination of first line treatment of patient with PD-L1 positive metastatic TNBC. SG plus Pembro led to the statistically significant and clinically meaningful improvement in the PFS versus chemo, and PFS benefit were observed across the pre-specific subgroup. OS data is still immature, but an early trend toward OS was seen, and overall response rate was higher, including a complete response rate, and response were more durable in the SG plus Pembro arm. The safety profile was also in the SG plus Pembro was consistent with the established profile of either agent. No additive toxicity was observed. Result from Keynote D90 support the use of SG plus Pembro as a potential new standard of care for the patient with previously untreated PD-L1 positive, locally advanced, unresectable, or metastatic triple negative breast cancer. Thank you so much, and sorry for this technical glitch.
No issues, Dr. Deepak. It happens sometimes. So anyway, I think overall you concluded well. And Ascent 4 was a good attempt to see the role of ADCs and immuno in first line, because the outcomes with the standard chemotherapies, even with combination with IO, was still very dismal, and there was a huge unmet need in this area. But even with the results of Ascent 4, there is a marginal benefit in PFS of 3 to 4 months. And I think in developing countries and the kind of patients which we see, chemotherapy plus minus immuno still holds the important treatment in our scenario, seeing the logistics. So
Yeah.
I think we need to wait more to have something good agent with good response rates and durable response rates leading into a good PFS and OS in metastatic breast cancer. So,
Yes, as we have seen in
so moving forward, we'll be moving to our next study, which is DB09. DB09 has been into a lot of talks nowadays because of the results which we have seen with that. So it's a use of trastuzumab deruxtecan along with pertuzumab versus the standard of care taxane plus trastuzumab and pertuzumab. That is the Cleopatra strategy in the first line treatment of HER2 positive advanced or metastatic breast cancer. So for that, we have with us Dr. Mohit Saxena. He is a senior consultant and head of department at Medical Oncology, Manipal Hospital, Gurgaon. Over to you, sir.
Good evening, sir. Thanks, Ankit sir, for giving me the opportunity. So my slides are visible, I think.
Yes,
My
sir.
slides are
As well as
visible?
you're audible. Yes,
Okay.
yes.
Okay, so just I just need, okay. So the topic given to me is just I will, yeah. So the topic given to me is trastuzumab deruxtecan, that's TDXD plus pembro versus taxane plus trastuzumab plus pertuzumab. That's TDXD versus THB for the first line treatment of patient with a human epidermal growth factor receptor 2 positive, HER2 positive, advanced or metastatic breast cancer. We are presenting interim results from Destiny Breast 09 trial. So of course the platform is already said, we have already discussed what's new in hormone positive breast cancer and what's new in triple negative breast cancer. Now we will discuss with Destiny Breast 09. That's and of course we are going to talk about the molecule of the decade, that's trastuzumab deruxtecan. There is a lot of buzz about this molecule, and of course it is already proven value in the second line and went beyond. So now we'll move to the first line. Of course, Destiny Breast 2 trial shows its superiority in comparison to Trastuzumab plus physician's choice in third line or more. Destiny Breast 03 is also a breakthrough trial because previously the standard of care was TDM1 based on the Emilia trial, which has shown superiority over LabCap, but now it's Destiny Breast 03, which has shown that TDM1 is no way around TDXD. It is you can see the median was 28.8 months versus 6.8 months only in Destiny Breast 03 trial. So that makes it standard of care in second line trial. But problem here is that only 1 in 3 patients receive subsequent line of therapy. So that's the problem. So so we should use our best molecule upfront. So as of now, we have standard of care Cleopatra. That's taxane plus trastuzumab plus pertuzumab, and we know that it gives PFS of around 18.5 months. Whether we can achieve more than that, that's the question. So the rationale is quite clear. Of course, the pertuzumab leads to binds to domain 2 and prevent heterodimerization, and trastuzumab binds to domain 4 and prevents homodimerization. So there is rationale behind combining trastuzumab and pertuzumab is to prevent homodimerization and heterodimerization. So that leads to inhibition of downstream signaling pathway, that's PIK3, big 3CA, AKT, mTOR and all. But here it's not just trastuzumab, it's trastuzumab deruxtecan. It's antibody drug conjugate. So it releases the chemotherapy inside the cell after internalization. And of course, we know that deruxtecan is topoisomerase 1 inhibitor, so that leads to cell death. And there is bystander effect as well. So not only the deruxtecan, which is released inside the tumor cell, having the HER2 positive HER2 receptor, the testosterone gets released to the nearby tumor cell also and kills that as well. So that's the beauty. We are killing the cancer with the 3 mechanisms. So that's the rationale why we want to combine these 2 molecules. Why we want to add trastuzumab deruxtecan to pertuzumab. Now, of course, we know about this is the randomized multi-center open label phase 3 trial. The eligibility include HER2 positive advanced or metastatic breast cancer patient, asymptomatic or inactive brain mets allowed. DeFi should be more than 6 months if last chemotherapy or HER2 target therapy neoadjuvant or adjuvant setting was taken. And 1 line of endocrine therapy was allowed in metastatic setting, only endocrine therapy. We do not allow any systemic therapy in the metastatic setting. Once patient is metastatic, then patient qualifies to this trial. And if patient has received any line of chemotherapy or something, then patient will be excluded. Now they are divided into 3 groups: TDXD plus placebo, TDXD plus pertuzumab, and of course our Cleopatra, that's THP, taxane plus trastuzumab plus pertuzumab. Now the primary endpoint was PFS by blinded independent central review. The key secondary was OS. Of course, we want to know about the OS. But the other secondary points are PFS by investigator, overall response rate, duration of response, PFS2. Of course, we want to know what will happen after this patient progress through this regime, and of course the safety and tolerability. But here we will discuss only about the plan of the TDXD plus pertuzumab versus THP. We will not discuss about TDXD plus placebo in this group, this interim analysis. Now, of course, the statistics say that or at the time of interim analysis, there are 399 events should be there across 3 arms and 277 per comparison. The maturity is 38% of total number for the PFS, and of course, the superiority is already proven. If you look at the OS, then there is 126 event have occurred. So the maturity is 16%. Of course, we need to wait for the final OS analysis. It will take time. Now, if you look at the patient disposition, then of course 383 patients were randomized to TDXD plus pertuzumab, and 387 were randomized to trastuzumab plus that's Cleopatra regime. And among these, in the TDXD plus P group, 59.7% discontinued. You can see only 21.3% because of progressive disease and 20.8% for adverse event, rest the different reason. While in the taxane, it is 18.8% because of the progression, 25.8% for adverse event, and rest other reason. In the trastuzumab, 52.5%. You can see the progression is much more in the trastuzumab group among the 66.6%, and because of adverse event, it is 3.4%. So what we also want to discuss this thing that in TDXD plus pertuzumab, 8.7% of patients were switched to trastuzumab plus pertuzumab after discontinuation other than PD. So that we should be keep in mind. There is slightly crossover is there. Endocrine therapy was added in addition to the therapy in 13.5% with the TDXD plus pertuzumab arm versus 38.3% in the THP arm. At data cutoff, 39.6% patients were receiving any kind of treatment, 45.8% with the TDXD plus pertuzumab and 33.4% with the THP arm. So there are sizable number of patients were actually still on treatment. Duration of follow-up was 29.2 months. Now, of course, if you look at the demographic, then of course all are female. The Asian are sizable number, that's 49%. So we can see that this results are significant for us. If we go for 2/3 were ECOG 0 and 1/3 were ECOG 1. ISC 3 plus were almost 83%, and rest ISC negative fish positive, ISC less than 3 or fish positive also. So almost 54% patients were hormone receptor positive. So hormone receptor positive status were also included, significant number. De novo diagnosis was almost in 50% patient. PIK3CA is 30.3%. So it is important. We have seen that PIK3CA is in downstream pathway. So we want to know whether this regime is helpful for patient with PIK3CA mutation or not, because it is a downstream pathway. So we know that trastuzumab plus pertuzumab patient will develop resistance to treatment if patient develop PIK3CA in future. Now, brain mets were almost 6.5%, 6% around. Visceral mets were sizable number, or more than almost 70% in each arm. So significant patients were having visceral metastasis. So they were high burden disease. Now, of course, almost 43% patients have received neoadjuvant or adjuvant treatment, chemotherapy in 40 around, and endocrine for 19 around, and target therapy for 29 around patient. But if the patient are advanced or metastatic setting, the endocrine therapy was received in 1.3% of patients. So patients have not received any systemic therapy once they have become metastatic, except the endocrine therapy, that's only in 1.3% patient. Now, if you look at this graph, this is the most important graph, I think, and that's what we want to see. And there is you can see the median PFS was 40.7 months with the TDXD plus pertuzumab versus 26.9 months with Cleopatra. So it's you can see delta of 13.8 months. If you look at 2-year data, then it's 52.1% with Cleopatra versus 70.1% with TDXD plus P. So you can see almost 18% difference in at 2 year. And if you look at the hazard ratio, then again it's impressive. It's 0.56. That is 44% relative risk reduction. So it's important. It's impressive. We can see. And of course, we would like to say that what the investigator was saying. So they were also saying the same thing. The 40.7 months versus 20.7 months. So here is delta of 20 months. The hazard ratio is 0.49 here. So of course, 51% relative risk reduction. So of course, both BICR and investigator assessment were same here. And this combination is definitely beating Cleopatra. We can see looking at this graph, at least in terms of PFS. Now, if you look at the subgroup analysis, then you can see all slides towards the left. Doesn't matter patient is having de novo mets or recurrent, patient is hormone receptor positive or negative, PIK3CA. PIK3CA whether detected or not detected. This regimen is superior to Cleopatra. We can see the PFS is all, or of course the age doesn't matter, the area doesn't matter, as the brain mets present. Of course, we know deruxtecan has very good brain penetration, almost 45% response rate in CNS is there. So of course, this regime is effective in brain. Prior exposure to anti therapy doesn't matter. So of course, this regime is effective in comparison to Cleopatra in all subgroup analysis. Now, if you look at the overall response rate, that is 85.1% with TDSD plus P versus 78.6 with the THP. Now, the beauty is that here we are getting 15.1% complete response. There is nothing left, while it is only 8.5% with the THP. And it's not about the response, it's maintained as well. Median duration of response is 39.2 months with TDXT plus P versus 26.4 months with THP. So we not only get better response, the response is maintained as well, and even more than 3 year on an average. So that's what we want, that patients are responding greatly and the response is durable. That's what we can say with this plot. Now, of course, overall survival, there is only 16% maturity. We need to wait for the long-term result. But if you look at the curve have started separating. And the hazard ratio is here 0.84. So there is 16% relative risk reduction. So early US trend shows that there is positive trend favoring TDHD plus B versus, of course, THB. Now, if you look at PFS2, what will happen once patient progress? Then, of course, there is a data maturity of 20-30% here. Median is not reached with the TDXD plus P versus 36.5 months with the THP. So here hazard ratio is 0.60, means 40% relative risk reduction. So again, it's impressive. Of course, we can see that what patients are taking, of course, in TDXD plus P arm, patients were taking 1.6% patients have taken TDXD, 1.8% of TDM1, majority have taken Tashimo continued regime or Pertimo continued regime. But again, we can see that not everyone goes to the second line.
Sir, sorry for intervening. Need to conclude, please, sir.
Okay. Okay, so you can, if you can look at the safety, then of course the safety data are well as per expected. The almost 54% grade 3 or more side effects are there. The deaths were 5 in the TJC plus B arm related to treatment. One for pneumonitis, sepsis, septic shock, febrile neutropenia, dyspnea related. So of course we need to have cautious about that. The nausea, diarrhea, neutropenia, fatigue are more common side effects. But important, the grade 3 or more side effects are neutropenia, leukopenia, and thrombocytopenia. Of course, we want to know about the ILD. So any grade is 12.1% with the THP plus P versus 1% with the THP, and grade 5 was in 0.5%. LVD, if you look at the 11% versus 7.1% in the THP plus P versus THP, and grade 3 or more is 2.1 versus 1.8%. Now, to conclude, TDHD plus P has statistically significant and meaningful PFS benefit by BICR versus THP. The hazard ratio is here 0.56, and of course, P value is 0.0001. The median PFS is 14.7 months versus 26.9 months, so 13.8 months delta. The duration of response is more than 3 years. CRR 15.1%, that's very good versus 8.5 only. And early US says the trends are favoring this regime. Of course, and for PFS2 as well, the hazard ratio is 0.60, and of course we know about the safety data. So the key takeaway here is TDS plus P demonstrated a PFS improvement versus standard first line THP in HER2 positive advanced or metastatic breast cancer, with 44% reduction in risk of disease progression or death with TDHD plus P versus THP. Safety consistent with, of course, the known profile. So TDHD plus P might be become the new first line standard of care for patients with HER2 positive advanced or metastatic breast cancer. Thank you.
Thank you so much, Dr. Mohit sir. It's indeed a very important data, and with such a significant difference in median PFS, would you still like to wait for OS, or would you like to change your practice now itself?
So of course, the data is impressive. Sooner or later, I think we will get the approval for the FDA and all as well for this regime for the first line. But of course, the cost is prohibiting, and I would not like to use this regime as of now for everyone. But if I find a patient with a heavy tumor burden and might be having some, say, comorbidities which are preventing me to use Taxane in the first line, then at least I would like to discuss that whether this is also a case where we can use this regimen, and if the cost is of course not issue, but not for everyone. Of course, I would like to wait for OS data. In our country, of course, the cost is a major challenge, and another thing which is in my mind is that if I use this in first line, then what is next? So maybe to continue or something like that. And where will I put the lapatinib or TDM1 in my practice? That's the question in my mind.
May I allow to ask one question to Dr. Mohit Saxena?
Yes, sir, please.
So why you don't want to use in everyone? Why to select patient only? There is nothing like subgroup analysis which is not in favor of this combination. First thing. Second thing is when the PFS2 benefit is there, I will not wait for the overall survival data to come to use it. What's your insight?
So of course the data is impressive. Sooner or later it will become a standard of care. We know about this. But only thing is that my hitch is of course the cost is of course if we forget about the cost, of course the data is impressive. But of course in the metastatic setting we already love to see the OS data whether it will change or not. It's only 16% of maturity as of now. Sooner or later I think we will get the approval for everyone.
But the
PFS
point is, with the 40-month median PFS, I think OS is definitely going to come positive. So if you have to change your practice, the PFS is such a drastic difference is there that we can change it right away. Only thing my concern was, what about the toxicity? Would like to learn about the toxicity in detail about this trial patients, and then decide not whom not to give according to the toxicity who are susceptible to that toxicity. Somani sir, any comment on that?
For any drug, any protocol, if there is an absolute contraindication or relatively higher contraindication, obviously we will not use it. As far as the breast is concerned, all subgroup analysis except the very elderly person, logically, it is in favor of this combination. And as we understand that this drug in the HR positive patient, whether it's the third line comparison, whether it's the second line, whether it's the TDM1 comparison, everywhere it has scored over the comparator arms. So I believe that this was also due, and Destiny 909 has shown it that yes, it's far ahead. And I am confident of the PFS2. If the PFS2 is showing the results, then I probably would not like to wait for the overall survival rate.
Okay, sir.
Yes.
PFS1, PFS2, significant. That itself for me is sufficient to recommend it to the patient. Cost is secondary thing. ILD is for select patients, I mean, and there is no predictive marker also for ILD.
Yes,
That, and especially in the breast, suppose previously patient had some bad radiotherapy and already there is evidence of some RT-induced damage and they are metastatic disease, maybe you can think of not giving it or any pre-existing disease or history. Otherwise, for the breast patient, ILD usually we don't get it in the upfront setting, and whenever there is, yes, you will stop it. But ILD there is no predictive marker also.
Yes. So, in the interest of time, I would like to thank Dr. Mohit once again, and we'll move forward with our next talk. This is again on TDXT, and it's a sponsored session by AstraZeneca. So, this talk is on the use of trastuzumab deruxtecan for the treatment of HR positive HER2 low and HR positive HER2 ultra low metastatic breast cancer. And to deliver this talk, we have with us Director Medical Oncology at BLK Max Super Specialty Hospital, New Delhi. Over to you, sir.
Can you see my slides and you all can hear me, right?
Yes, sir.
Yes, sir.
Thank you.
Please make it
Ankit.
full
can
screen,
just
sir.
I shall make it right 1 second. No, it's not. It's done. No, it's not making it 1 second. It's not allowing me to edit it. So not able to make
Sir,
it.
you can click on enable editing and
Okay.
read only mode.
Okay. Right.
Read only mode, then you can make your slide full screen.
That is also not clicking in. So we need to go to the slides or what?
Sir, if you permit, we can share your slide from
Yeah,
our
yeah,
end.
can share from that. So I
Okay.
can take it over. I'll read only. I got it. 1 second. Wait. Yeah. Now it's fine. It's fine.
No, sir, you need to reshare your screen, sir.
Where do we scan it? Right. Yeah. And now?
Yes, sir, perfect.
Yeah,
Perfect.
thank you. So sorry for the glitch. So it's going to be what Mohit spoke about HER2 positive. Now it will be in HER2 low or ultra low category. This is a overview of a TDXT, that introduction, background, unmet need, and HER2 mechanism has already been told. I will not cover that in detail. Destiny Breast 06 study design, which I was a part of, and 06 efficacy, safety, and health related quality of life data, and the adverse event management with respect to the TDXT and the summaries. So we know that we have a subset of HER2 negative candidates who may be ultra low or low. So these are the subset which we need to find out so that these chunks should get a benefit from the drug that is TDXT, as it has shown a good response, which we're going to speak later. So this chunk constitutes almost 1/4 of the patient. So that's a significant chunk, which we need to train our pathologists to make sure that you need to find out this HER2 low and ultra low category. This is just a definition of HER2 2 plus, 1 plus, 0, which it has a faint membrane. This is where we need to concentrate our ultra low, where it is less than 10% of the tumor cells which with a faint incomplete membrane staining. This is an ultra low category which constitutes 1/4 of the patients. So this is where unexplored territory, and it needs to be managed with the TDXT. So what we have learned from the history is that endocrine therapy alone or with the CDK4/6 inhibitors, we achieve a PFS around 2 years. Subsequent lines of treatment post failure of CDK4/6 and EI has resulted in single-digit PFS benefit. And whatever we had with barring the one of the PI3K inhibition, which gives us around 10 months of benefit with a lot of toxicities. So that made us think that yes, down the line we need to after the first CDK4/6 inhibitors, we need something to fit into extend this particular survival. And if you can see the discontinuation rates or a patient through an attrition, almost 50% of the patients go into attrition before they reach the third line. So 18, 17, 18%. So that is a significant chunk of patients. Almost half of the patients would lead to attrition. This has already been talked about the bystander effect by Mohit Saxena. I don't want to go into the details of it. And coming directly to Destiny Breast 06 trial, and it is the hormone positive, HER2 negative MBC, with the HER2 low defined as 1 plus or 2 plus with ish negative, or HER2 ultra low, which is a 0 with a membrane staining. And they should be chemotherapy naive in the metastatic setting. They should have received more than 2 lines of treatment if it is an endocrine therapy without the targeted agent like CDK4/6, or more than 1 line of MBCs, more than one line of the endocrine, which has progression. It's kind of an endocrine, a primary or a secondary endocrine resistance. So less than 6 months or less than 24 months. So that's also was considered, and they were enrolled between TDXT or treatment choice physicians chemotherapy. And primary endpoint was the PFS by independent review in HER2 low, and the various key secondary endpoints in the HER2 low, ultra low, and including overall survival in HER2 low and intention to treat population, and various other secondary endpoints. And the stratification was done with respect to a prior patient who has received a CDK4/6, HER2 expression, whether it's 1 plus 2 plus, is there an incremental benefit? Or what about the ultra low setting and the prior taxane in the non-metastatic setting, was it received or not? So these are the demographic and K baseline characteristics which were well matched between the arms. Just wanted to draw attention to HER2 low category. So there are almost nearly around 80 patients in each arm to see the whether it's going to benefit in this particular subset as well. So this is again the various the other clinical characteristics, where the number of metastasis and hormone positive HER2 victims, almost hormone positive ERPR positive is almost 60%, ER positive PR negative is around 40%. So this is how it was divided into, and the HER2 1 plus cut was almost 70% in all subsets. 2 plus were a bit less. So HER2 low were that's HER2 low. Ultra low were minimal as was seen in here. So the lines of endocrine therapy was also well matched between the two. And this is the efficacy and the safety related data. And if the primary endpoint of independent review, there's a progression-free survival, there's a delta of 5.1 favoring TDXT. So that's 8.1 versus 13.2 with the hazard of 0.62. So this demonstrated that it statistically significantly increased the progression-free survival in a HER2 low category. So when you talk of PFS by an intention to treat population, there also the delta was maintained as 5.1 favoring TDXD. So if you segregate the data into HER2 low or intention to treat population HER2 low category, so in a case secondary endpoint at a 40% maturity, in terms of overall survival, however, there is actually hazard of 0.83 and 0.81. So still there is a separation, but it wasn't a significant advantage in there. So if you have a subgroup, if you see the subgroups of patients, the PFS was consistently improved in patients who have a TDXT across all the subgroups. So be it load of the disease, be it the primary endocrine resistance, the secondary endocrine resistance, irrespective of the chemotherapy there. So it's all those are favoring a TDXT. And the PFS OS in HER2 ultra low category was also seen, as I said, around 78 patients were enrolled. The PFS in the TDX were again delta of around 5 months favoring TDXT. The overall survival is with hazard of 0.75. So that's the data in ultra low category. See this waterfall curve. So the right hand side, in the brown is around the chemotherapy. The blue is TDXT. You can see how, as expected, in the HER2 low intention to treat and the HER2 ultra low, the response rate is almost 60%, doubling of the response rates compared to the chemotherapy arm, the comparator arm, which is around 30 across the groups, and it's around 60 across the groups where a patient has received a TDXT, indicating that there's a doubling of the response. So that was actually, if you can see, just not it's a stable disease, it's more of a partial responses. So more than 50% of the patients with the TDXT achieved a partial response. So that's also a significant number when you talk of this particular drug. So PFS by time to progression on first line endocrine and CDK4/6 that's the endocrine resistant category. So sometimes when you have a discussion that a patient progresses, and we have seen a lot of patients progressing on first line CDK4/6 inhibitors, and you fall back immediately on either chemotherapy without waiting for the fulvestrant to come in. So this is a category where you need to explore a little bit more in terms of HER2 low and HER2 ultra low category. Instead of chemotherapy, the TDXT has shown a benefit, and this needs to be clearly looked into. The PFS2 also, as was talked about, that it has a spillover effect in subsequent lines of treatment. So hence, this is significant. The PFS2 is also favoring TDXT. So if you talk of a disease burden, as I said, once we have a response rates which are better, hence, irrespective of the disease burden, the TDXT is beneficial. Better, be it less than 2-3 local or metastatic sites, or more than 3 local or metastatic site, it favors the TDXT. Coming to a safety profile, the overall safety, as we know, it is a highly emetogenic drug. So we need to definitely be careful about the emetogenic potential and should use a highly emetogenic the protocol that we come across like ACs and CHOP. So all those protocols should be implemented when you use a TDXT. So that is the one. And the neuropathy, that is what is important that we need to take care of that. And other thing is the interstitial lung disease. So interstitial lung disease is seen in around 10% of the patients, and this is also a few number of patients, maybe around almost around 15 to 20 patients which I'm treated, and I've seen only one. Rest, I saw that the other patient did not have any the interstitial lung disease. Don't want to go into the depths of all these as it was already talked about in the previous by the previous speaker. So what we need to know is that the quality of life is definitely when you have a response, when you have the disease burden more in the metastatic setting or an endocrine setting, if there is a response, the quality of life would be much more better when that particular patient responds. So to conclude, TDXT demonstrated a statistically significant and a clinically meaningful PFS benefit versus treatment physician choice of chemotherapy in a hormone positive HER2 low MBC in an earlier line of treatment than the Destiny Breast 4. The results of HER2 ultra low were consistent with HER2 low and confirmed overall almost 60%, which is which is more doubling of double than the conventional chemotherapy. And there's no new safety signals were identified. ILD remains an important safety risk with some of the deaths reported out of that. We need to be cognizant of those symptoms and detect it at a grade 1, treat them with steroids. So in a grade 2, then you need not have to use it again. So that's the takeaway. And Destiny B6 establishes the TDXT as an effective new treatment option for patients with hormone positive HER2 low and HER2 ultra low MBC following more than one endocrine based therapy. Thank you very much.
Thank you so much, Chandragada sir. Indeed, it's a very important study and it has changed the second line treatment of HER2 positive, HR positive and HER2 low and ultra low category. We need to focus more on the testing aspect as well because we need to sensitize our pathologists to diagnose this ultra low HER2 positive, ultra low metastatic breast cancer because these kind of categories of patients should not be missed. So thank you once again. Moving on, our next talk is it's on umbrella extension study result, and this session is sponsored by Roche. For this, we have with us Dr. Naresh Somani sir. He is the head of medical oncology department at SCG Cancer Center, Jaipur. He's a director and senior consultant at Somani Hospital, Jaipur as well. So over to you, sir.
Thank you. Thanks, Dr. Batra, for this wonderful opportunity. And let me share my slide, my end. Is it visible?
Yes, sir.
Okay, so I need to go to the full screen. Okay, so I have been asked to speak about the 6-year survival in patient with the extensive stage small cell treated with the atijope with chemotherapy in the IM Power 133. We all know about this particular trial and the other similar trials and results of that, and that is sort of the standard of care because simple chemotherapy, doublet chemotherapy, which we often use, hardly gives any 5-year survival. That is only to the tune of 1 to 2% or something like that, and hardly anybody is there for the 5 years. Now, IM Power 133, the simple schema, that is the carboplatin etoposide plus atijo versus placebo. The co-primary endpoints were the overall survival as well as the PFS. And this particular trial, which is considered as one of the true standards of the care, which we often use in our practice, that is either atezolizumab or the durvalumab in our practice. And when we look at the results of this trial, we see that at the end of the 12 months, there is a separation of the curve and there is a significant overall survival difference. And there is a reduction in the risk of the death to the tune of the 30%, which is quite clinically meaningful and which is quite statistically significant also. Atezolizumab plus this combination continued to show the improved overall survival versus the placebo plus chemo at the recently updated analysis also at the end of the 18 months, then subsequently at the 24 months. Also, that is 22% versus 16%. And based on this, this particular combination is being used. Though results are not so good, but yes, statistically significant difference is there. And this has scored both for the PFS as well as for the overall survival also. And if we look at the separation of the curve, we see that they're quite early at the end of the 5 to 6 months. There is a separation of the curves. That means clinically meaningful symptomatology improvement as well as the outcome is there. Now, updated safety profile of this particular trial was consistent with the known risk of the individual treatment component. So nothing new was there in the updated analysis as far as the side effects were also concerned. And they were consistent as per the side effects of the chemotherapy or the immunotherapy for that matter. So this trial was summarized as the first positive trial of the combination of IO plus chemo. And this combination was the first major treatment in the first line treatment over the last 2 decades, giving a clinically meaningful improvement in the overall survival over the current standard of care, that is the doublet chemotherapy. And this is recommended as per the various guidelines and other key treatment guidelines for the first line treatment, both from the NCC and ISMO and other major guidelines. And we all are using this sort of the combination, but we should not forget that if you look at the subgroup analysis of this particular trial, probably the brain metastatic patient, they were not so being benefited in this particular trial. And this trial was based simply on the etoposide plus carboplatin. Cisplatin was not used in this particular trial. Now, further extension of this is the 6-year survival data in patient with the extensive stage treated with the atezolizumab with the chemotherapy in IMpower 133. That is IMbrave1 extension study results. So they just try to follow these patients who were getting the treatment consistently, and they could follow around 18 patients in this particular trial. And even those patients who rolled over on other treatment also, they tried to follow this. And those patients after the cutoff of the clinical data, when they were rolled over and they continued to have the treatment, they were being studied in this particular trial. And if you look at the characteristic of these patients, the median age, the age group, and the other factors were more and less similar. So the number of patients in the extension, that is the 6 years data, were only 18 patients in the number. So that's obviously the quite low number. But if you look at the 5-year overall survival data, that remained quite impressive compared to the historical data of the combination chemotherapy, that is the 5-year data of the 12%, which is hardly being reported by any meta-analysis or by any particular trial of this combination of the doublet chemotherapy. So IMpower 133 and Umbrella, a 6-year overall survival data consistently showed that the combination of the chemo plus atezolizumab is beneficial for the patient, and this benefits because of the immunotherapy addition is almost giving the plateau to these patients, something which we talk or which we often observe in the NSCLC patient treated with a single agent IO or treated with the IO plus combination chemotherapy. So around 20% of the patient, they achieve the plateau in the NSCLC, and around we can say that 12% of the patient, they achieve the plateau in the small cell lung cancer also. And this is about the further details of the patients also. So safety outcomes, if we talk, nothing new is there. The grade 3 and 4 toxicity remained more and less similar, though the complete data were not being reported. But obviously it speaks that the patient continued on the treatment. Obviously, they were tolerating the treatment well. Now, if we look at the other clinical trials compared to the 133, that is the Caspian trial, which we often talk, which we sometimes use in our clinical practice, that is essentially more and less similar, durvalumab plus etoposide plus platinum, combination chemotherapy, If you look at the first year, second year, third year data, they are almost similar to this. If you look at the pembrolizumab data, they are slightly inferior numerically, though this all is that cross-trial comparison. We cannot make the direct comparison of these. But yes, these two combinations, that is the durva-based or atezolizumab-based, are quite in practice. But here, the positive thing is that the 6-year data are now available with the atezolizumab, which is quite satisfactory for our patient, though it is not complete. Now, the very recent, in the last 1 week, the buzz which has come in the Indian market is the availability of the another molecule, that is the Astrum 005. And this is again, the schema is the same, that is the extensive stage small cell lung cancer, various stratification factors were there, the carbo plus etoposide plus another PD-1 inhibitor. The previous two molecules were obviously the PD-L1 inhibitor, and this is the first PD-1 inhibitor showing the results. And if we look at its approval and the magnitude of the benefit, yes, the serplulimab has is making the buzz, and it's now available with us also. So we need to understand that how to place these molecules in the extensive stage disease. And this particular trial has also shown the improvement in the progression-free survival. But in spite of these all positive trials and being in the practice, we understand that outcome of the extensive stage disease is not so good. It's a dismal at the end of the 2 years, 3 years, and subsequently. So one more new study molecule is now being there, and that molecule is again showing probably the first time at the switch maintenance in the small cell lung cancer, the positive result. That is the combination of the chemotherapy plus atezolizumab as the beginning treatment. You give the 4 cycles, continue the atezolizumab in the responding patient, and then you add the another drug, that is the ADC, lurbinectedin, and that has again shown the positive result. I think these results were being presented this time in the ESCO. So with this, and that may become the another standard of care. So if we talk about the Indian market, these 3 molecules, atezo plus durva plus now the serplulimab, are available with us. They have their own pros and cons. But yes, with the 6-year data of the atezolizumab, we need to understand that how it is important to follow these patients continuously and to see that what happens with these patients long term. And IM4 again, yes, there's a new molecule is coming. So with this, I would like to conclude saying that in the extensive stage disease, in the beginning of the treatment with the help of the IO and subsequently with the new ADC, there is a lot of improvement going on. And maybe very soon we will see these results matching at par with the NSCLC NSCLC advanced stability. Thank you.
Thank you so much, sir. It's indeed a very important data and showing at the importance of using immunotherapy in small cell lung cancer, and then reaching up to 5-year survival data, which was never talked about previously. And definitely, although a bit late, but small cell lung cancer is also catching up with other disease to improve upon the survival. So thank you so much for your talk. In view of as we are running short of time, we'll move on to our next talk, and it will be resuming back to the breast cancer. And this talk will be about the diagnostics, the role of onco-free testing in the breast cancer. So it's a new indigenous test which is being used for the prognostication of breast cancer, the use of chemotherapy in early stage hormone receptor positive, HER2 negative breast cancer. And for this, we have Dr. Ram Kumar with us. He's a senior research scientist at Dr. Lal Path Lab, that is Gene Evolve. So over to you, Dr. Ram.
Am I audible?
Yes, sir, you are audible. Please make it full screen, sir.
Yeah, good evening, everyone. Just Will I start the talk about role of onco-free testing in breast cancer. So first we need to know about what is onco-free. Till time we have discussed about drug
Sir,
trials
sorry
and
for intervening. Your slides are not moving. This is still in.
sorry.
Your slides are not moving, sir. Now it's working. Yes, sir.
Now
Make it full
moving.
screen, sir.
Full screen.
Yeah, it has been fully screen. Now it is moving.
Sir, it is weak. It is not full screen, sir, as we can see.
No,
It is moving, but is it not? It is not a full screen, sir.
no. Actually, I have made it full screen from my side. So just I'll start again. Cross it. Save it. Yeah, now it is moving.
Sir, you need to share your screen. Actually, this you haven't shared yet, no?
No, I
You
have
need
shared.
to. No, no, you need to share again your screen.
Yeah, so now
Yes, sir.
moving.
Perfect. Perfect.
Okay, yeah,
Perfect.
thank you. So just I'll start. So what is onco-free? Onco-free is a next generation sequencing based on multi-gene assay that predicts the risk of distant metastasis in hormone receptor positive and HER2 negative early stage breast cancer patients. So it analyzes the expression of almost 179 genes to determine a decision index score, which helps guide decision about chemotherapy. So just breast cancer status worldwide. So almost 2.26 million patients worldwide, in which almost zero point 0.9 million patients of onco-free, almost 40%. In When we talk about Asia, so we have almost 1.026 million breast cancer patient, and almost 40% case of has been treated by onco-free. So this one is the breast cancer status in Asia. So we are in right in 2022, almost 985,000 new cases and 315,000 deaths occurred till 2022. And India and China are leading contributor in new cases and deaths. So by 2050, it will be 1.4 million new cases and 0.5 million deaths will maybe occur. So for removing these things, we need to diagnose in earlier stage of breast cancer. So for that, we need to identify the cases in earlier stages. So what will be necessity of breast cancer prognosis testing? So only 20% patients are eligible for chemoendocrine therapy. So we need to identify that those patients. So it becomes important to accurately identify patients who need chemotherapy and who need hormonal therapy. So breast cancer prognosis test can objective indicator for chemotherapy decision. So this one is the National Comprehensive Cancer Network. They have also suggested the test onco-free test for HR positive and HER2 negative cases. According to NCCN published data, they have recommended HR positive and HER2 and lymph node negative patients for onco-free. So characteristic of breast cancer patient in Asia. So incidence and mortality rates for cancer in Asia is breast cancer is the most common cancer in Asia. In Western countries, the incidence of breast cancer is high in the elderly patients, but in the Eastern countries, the incidence is the highest in 50s. In left side, we can see the maximum cases of breast cancer, and mortality rate is almost equal to the lung cancer. But lung cancer cases is very less compared to breast cancer. In right side, we can see the breast cancer age standardized incidence rates. So in USA, it will be occurs in late stages, but in Asian countries, it has been in 50s. So how it has been developed? So it has been developed in 430 samples long-term follow-up data, and their inclusion criteria like invasive breast cancer, ER positive, HER2 negative, no lymph node metastasis, and almost 5 years follow-up their cases, and invasive tumor size should be more than 0.5 centimeter. So in that we have included 82 samples with distant metastasis as well. So onco-free eligible patients. So who are eligible for the onco-free testing? So this one is the early breast cancer cases. So tumor size should be more than 0.5 and less than or equal to 5 centimeters. And hormone receptors should be positive, ERPR positive, and no lymph node metastasis, and HER2 receptor are negative. So OncoFree can help to make a treatment plan for early breast cancer patients who have undergone breast cancer removal surgery and are eligible for an endocrine therapy and chemotherapy. So this one is the basically protocol how test will be performed. So just we need to extract RNA from FFP block or slides, and thereafter we need to sequencing by NGS, next generation sequencing, and their alignment with the reference sequences, and analysis with OncoFree algorithm. And based on that, the test will be provide the score, decision index score, and if a score is 20, so it will be a score is low, and if more than 20, that will call the high. So this one is the first world NGS-based breast cancer prognosis test. And in this, we are including 179 genes to predict the risk of metastasis and recurrence. So it has been developed on Korean uh, and Asian population. So key feature of onco-free test. So NGS based test, this one is the first NGS based test. So in this large amount of genomic data can be processed with a small amount of RNA. And this has been higher sensitivity, reproducibility, and flexibility compared to early test QRT-PCR. More genes can be analyzed at a relatively low cost. In earlier test, we will discuss in later slides. So in this one is the Asian specialized test. So secure high prognosis power using genomic data reflecting Asian breast cancer characteristic, even distributed demographics, make up for the weakness of existing test with high price ranges and long test periods. So gain economic and temporal benefits through localization, which is an advantage of NGS. So currently, this one is a test available with different companies. Oncotype DX, so they are doing analyzing only 21 gene, and this one is available on QRT PCR. And MemmaPrint has available, OncoFree has been available, and they are included only 70 genes. And in this case also they are HR positive and HER2 negative. And And IndoPredict, they are only included 12 gene, and Prosigna, they have included only 50 genes. But in OncoFree, we have included 179 genes. So how test will be performed? So for this test, we need FFP block or 10 unstent slides. So thickness of slides should be 10 micromolar, and this can be used for the multivariate index assay. We are already, as I have already mentioned, so this can be after RNA expression data, we can analyze 179 genes which we have selected for this test, and based on that analyzed data, we will provide decision index score. So this one is the report, how we will uh, provide the report. So this, if a score is less than 20, so it will be a score, result is as low, and patient is on low risk. So and their survival is in almost risk of distant metastasis in low score is only 2%, and in second of 5 years, metastasis risk is only 4.8%.
So sorry for intervening. Need to conclude, please.
Okay, yeah, thank you. So this one is low risk if a score is less than 20. If a score is more than 20, so that will be high recurrence and metastasis possibility. So OncoFree, if a score is low, so low possibility of distant metastasis after 5 years and 10 years as well. If a score is high, then metastasis possibility is comparatively high compared to low risk. In high risk, metastasis rate is 10%, and in 10 years is 22%. So thank you.
Thank you, Dr. Ram.
Can I ask him a
Is
question, if permitted?
yes, yes, please,
So,
sir.
as no Indian patients were there, is this sort of the test in India is being allowed by the DCGI to take the decision on the patient?
Sir, Asian population they have included, so therefore we have included, and we are developed based on that. Indian patient now included, and based we are continue to follow up for them as well.
So originally, this when it was developed, there were no Indian patients were there. Am I right?
Yeah, so yes, sir, agree.
So
That
how
I
you
have
got the, I mean, I'm just trying to understand. I'm not making the question mark. How you got the approval to in the routine clinical practice, and how can I be comfortable treating my patient, taking the decision to treat or not to treat? And this is basically risk of the recurrence. I think it's not the prediction of the response to the chemotherapy. Suppose risk of the recurrence is high.
yes, sir,
Is it giving this?
risk of recurrence.
Or are you planning any prospective data collection of that those patients who are having the high risk of the recurrence and then being treated with the chemotherapy, what outcome they have versus those who are not having chemotherapy in the low risk group and their outcome?
Yes, we
Because
have
retrospectively you won't get the correct data.
we uh, uh, we are continue to follow up, and we can discuss later as well. We have continuous
Dr.
follow up,
Ankit
and
Batra, what's
we
your
are.
opinion? What's your insight in this?
So I was going to ask the same question, sir, whether any Indian patients were there or not. So the answer is that they are only Asian patient, not the Indian patient. And I was going to ask whether they are planning or conducting any study on the Indian patient as well, because that only will give us more confidence because of the difference in the genomics and um other factors which we need to see as compared to the Indian versus other Asian countries or the Western countries. So that's a very valid reason. And also, this has been conducted on close to 1,700 patients. So we need more patients to validate it further.
Yes,
If
sir,
we
agree.
look at the simple example of the EGFR, we are somewhere between the European and the Eastern Asian incidence wise. So having the Korean study, we cannot say that the so-called Asian or Indian patients were there.
There should be definitely a study on Indian patients as well. I agree with you, sir.
At least what I will suggest to the Lalpath lab is that they should quickly come out of the results of the 100 patient, telling us that the risk of the recurrence is low versus high, which is at par or more or less compared to the Asian patient which they have done originally. At least to tell us that the risk of the recurrence as per this particular NGS-based system is the same or not same. Whatever number of the patient they are able to recruit.
Yes, sure, sir. Sure, sir.
And
But
also,
because being the NGS based and being the high number of the molecule mutations involved in this looks quite attractive.
yes, sir. So I was going to ask this only, that whether the doing additional number of genes, that is 179, is that making any difference or giving us any advantage as compared to the other tests? That also needs to be highlighted. So thank you so much, Dr. Ram. We'll be looking forward to more results from this test and studies conducted with this test.
Yeah. Thank you, sir. Thank you, sir.
Yeah. So with that, we conclude our breast cancer symposium. And before we move on to the lung cancer, we have an important update about the endometrial cancer. And this is again about the paradigm shift in the management of the endometrial cancer using the combinatorial approach of chemotherapy, immunotherapy, and the targeted therapy. And for this, we have with us Dr. Shivashankar Swami. Is a senior consultant medical oncologist at Rajiv Gandhi Cancer Institute and Research Center, Delhi. And this session is sponsored by AstraZeneca. Over to you, Dr. Shivashankar.
Thank you, Dr. Ankit. I'll share my slides. I hope my screen is visible to everyone.
Yes, sir. Yes, sir.
Thank you. So at the outset, I would like to thank the organizer for providing this wonderful opportunity to discuss the recent updates in advanced endometrial cancers. So we all know that, endometrial cancer is one of the common malignancy we see in our day-to-day OPD clinics. It constitutes around 22nd in the rank list among the incidence of all cancers in India. And if you look at the deaths due to uterine cancers, it ranked at 23rd. So roughly around 16,000 endometrial cancers are diagnosed every year, and roughly around 6,000 patients die due to endometrial cancers every year. 5-year prevalence of endometrial cancer is roughly to the tune of 43,000 cases. Similar to any other cancers, now we are moving away from, earlier it was like lung cancer, organ-based cancer, then slowly drifted to immunohistochemistry. Then slowly we are drifting to molecular level to better understand how each subtype of particular organ-restricted cancers will behave and what are the treatment options. So the story is similar even in the endometrial cancer. Now all the endometrial cancer are not same, and they are different in both aggressiveness as well as response to therapy. So in endometrial cancers, there are certain molecular markers which drive the genesis of these cancers, and among them it may be inheritable genetic mutations, or they may be somatic mutations. The most commonly observed inheritable mutations are MMR mutations, that is in MMR deficiency, or pole mutations. Apart from that, BRCA mutations, PTEN mutations can also be observed. Lynch syndrome, an inherited autosomal dominant syndrome, accounts for roughly around 3% of endometrial cancers. BRCA mutations, particularly BRCA mutations, are not that common in endometrial cancers, unlike ovarian cancers. Apart from that, some somatic PTEN mutations are also commonly seen in sporadic endometrial carcinoma, roughly occurring in 40 to 60% of cases. However, germline mutations are rare. That is, Cowden syndrome is very rare. And if somebody has a Cowden syndrome, the lifetime probability of having endometrial cancer is to the tune of 28%. I'll not go in detail about the staging. We all are aware. Stage 1 and stage 2 is localized disease, that is limited to uterus or uterus and cervix. Stage 3 is extending beyond the uterus, either to the vagina or the pelvis. Stage 4 is this directly involving the rectum, bladder, or distant metastasis. So similar to the stories of other cancers like lung, breast, stomach, the story is similar even in the endometrial cancers. Now we are moving to molecular classification of these cancers to understand better how they behave and what should be the optimal treatment options. So similar to TCGA molecular classification across various tumor types, we have one in endometrial cancer also. Pole mutation confers particularly in early stage, it confers a better prognosis. Pole mutated are usually they are having a high TMB, they are ultra mutated. Tumors have a brisk lymphocytic infiltration. They are highly responsive to immunotherapy agents. MSA high, that is MMR deficient tumors, they are also again they are highly responsive to immunotherapy, and also they may harbor other mutations like P10, ARID1A, PIK3CA, PIK3R1, and RPL22 mutations. Apart from these two, we have copy number low and copy number high. Copy number low may have P10, CTNNB1, PIK3CA, KRAS, ARID1. They are usually MSS, that is MMR proficient tumors. Among copy number low, if they have a CTN and B1, they are usually associated with a worse outcome than expected from these tumors with a favorable histopathological features. And other last subcategory in TCGA is copy number high. They are usually TP53 mutated. CCNA NE1 amplification is common. They are usually high grade, aggressive, and have a poor outcome. Coming to the importance of today's discussion, that is the advanced endometrial cancers. We all know that until recent years in advanced endometrial cancers, only treatment options were chemotherapy. Hardly we had a few chemotherapeutic agents which are active in endometrial cancers and with a single digit PFS and OS data once they are in the advanced endometrial carcinoma. So across the various stages, be it stage 1 to stage 4, surgery remains the cornerstone of management if surgically resectable. In stage 4, apart from surgery, the importance is mainly in systemic therapy. Until recent years, it was all chemotherapy. Now we have many targeted therapies and IO immunotherapies which have paved their way into the management of endometrial cancers, which particularly immunotherapy and PARP inhibitor we'll be discussing in today's discussion. So why we need to improve the management of this particularly advanced disease? As we can see in this bar diagram, if it is stage 1 and stage 2, 5-year survival is to the tune of 75 to 90%. This one drastically drops down to 20 to 30% if it is stage 3, stage 4A. And if it is stage 4B, it is almost 17%. That is only 1 in 5 patients will live beyond 5 years if they are diagnosed with a stage 4B, that is metastatic endometrial carcinoma. So patients with stage 4 disease are at high risk of recurrence and they have a very poor prognosis. And recently in the advanced stage disease, we have a combination of chemotherapy plus immunotherapy or immunotherapy plus targeted therapy options. So combination of IO therapy is now established as the standard of care in advanced endometrial cancers. This is the timeline of how these therapies are evolved in the management of endometrial cancers. Earlier, way back in 2015, we had a keynote 158 and keynote 146, which looked at the role of immunotherapy in endometrial cancers. Then in 2018, FDA approved based on keynote 775, FDA approved particularly in MSA high and MMR deficient endometrial cancers. In 2021, there was full FDA approval and EMA also approved for all comers irrespective of MMR status. So if you look at NCCN in 2025, this how the slides look for the management of endometrial cancers. If they are stage 1 to 4, the preferred regimens are carboplatin, paclitaxel, or pembrolizumab, particularly if they are stage 3 or 4 tumors. If you are choosing pembrolizumab in this situation, particularly in the perioperative situation, the carcinosarcomas are excluded and they should have a measurable disease. Apart from that, carboplatin, paclitaxel along with dostarlimab or chemotherapy plus durvalumab, all these three immunotherapeutic drugs have been already are there in NCCN guidelines. and also particularly if they are HER2 positive uterine serous carcinoma or carcinosarcoma, we can also use trastuzumab. So if they are in recurrent disease or in the metastatic disease, which are not amenable for surgery, then the preferred options are again similar to what we had seen in the previous slide. Chemotherapy plus pembrolizumab. One thing to be kept in mind while choosing pembrolizumab, in this trial, carcinosarcoma were excluded. Apart from that, we have a durvalumab or dostarlimab option can be used along with chemotherapy. All the three are category 1 indication to be used in endometrial carcinoma. So we'll look at the data which supports this guidelines. So first one is Keynote 775. This looked at role of immunotherapy plus lenvatinib in the second line setting. They randomized patient in 1:1 fashion to pembrolizumab plus lenvatinib versus treatment of physician choice. The primary endpoints were PFS and OS. So we all know that this pembrolizumab plus lenvatinib proved its efficacy across all the subgroups, be it proficient MMR or all comers. We can see in that updated PFS in the proficient MMR group, the median PFS was 6.7 months as opposed to 3.8 months in the chemotherapy. That is almost doubling. And even if you look at the final OS in proficient MMR and all patients, this is the bottom line Kaplan-Meier cursor, all patients, and the top KM cursor in proficient MMR, we can see that there is a clear separation of curves, both in PFS and OS, whether it is the proficient MMR groups or all comers. We know that deficient MMR groups do excellently well on immunotherapy, but also this for the first time has shown that even in proficient MMR, there is a role of immunotherapy plus lenvatinib. So apart from this, we have now also chemotherapy plus immunotherapy in the first line setting. That was in the second line setting once they progressed on first line chemotherapy. So in the second line setting, the trials looked at the pembrolizumab trial was NRG GY018. In this trial, patients were randomized to 2:1. They are advanced stage 3 or stage 4 and stage 4B are recurrent. If they are stage 3 or stage 4A, if they are underwent surgery, they should have measurable disease. They were randomized to chemotherapy plus pembrolizumab or chemotherapy alone. After 6 cycles, they were continued on placebo or pembrolizumab Q6 weekly. Instead of 3 weekly, it was 200 mg Q6 weekly. The primary endpoint
Sir,
was...
sorry for intervening. Need to conclude, please, sir.
Oh, it was just a 5 minutes. I mean, is it just a 5 minutes presentation?
Please continue, Dr. Shiveshan.
Okay. Thank you. So histology included, or unlike the DOE and Ruby trial, in this carcinosarcomas were excluded. So if we come to the primary endpoint PFS, we can see that there is a very nice separation of Kaplan-Meier curves in the MMR deficient groups as opposed to proficient MMR population. Though there is a good separation of curves even in the proficient MMR. In the proficient MMR group, the PFS was 13.1 versus 8.7 months. So again, if you look at the OS, there is also good OS trend in OS benefit in the deficient MMR, and also there is a favorable trend towards OS benefit in the proficient MMR as well. And they looked at the PDL1 status, whether it was PDL1 CPS more than 1 or less than 1, there was a benefit of addition of pembrolizumab in deficient MMR population. So the next trial which looked at the role of chemo plus IO was Ruby trial. Again, it is a randomized 1:1. They included dostarlimab plus chemo versus chemo alone. In this, primary endpoint was PFS OS. Here we can see that even carcinosarcoma patients were included in this trial, unlike the previous one. And we can clearly see that PFS in all comers, there is a definitely benefit of adding dostarlimab. In deficient MMR, the benefit is huge. So if you look at the statistic, there is a statistically significant OS benefit in overall population as well as in the MMR proficient population. In the MMR proficient population, though HR was 0.79, it was crossing the line of unity with 0.60 to 1.04. However, in the deficient MMR, there is a clear benefit in the OS as well. So dostarlimab plus chemotherapy showed a statistically significant and clinically relevant OS benefit in overall population compared to CP alone. So coming to the main, that is DuO-E trial, that is which looked at the role of durvalumab plus chemotherapy, and not only just durvalumab, they also went ahead and tried to look at addition of PARP inhibitors. We know that, I mean, like ovarian cancers and endometrial cancers have a somewhat similar behavior. So they thought that probably addition of PARP inhibitor may also benefit in these patients. So we know that when PARP inhibitors are combined with immunotherapy, there may be enhanced efficacy of IO agents, particularly when PARP inhibitors leads to synthetic lethality. There may be exhibition of some of the neoantigens which may improve IO efficacy. So that was the hypothesis behind adding immunotherapy plus durvalumab. This was a 3-arm trial which included chemotherapy plus durvalumab, or chemotherapy plus durvalumab plus olaparib. In the maintenance phase, either durva or durva plus olaparib or placebo was given. The primary endpoint was PFS, and the key secondary endpoints were OS and safety. So again, it was similar. It was, I mean, like roughly 1/3 of patients were Asian populations, and 50-50, the 50 were around newly diagnosed, 50 were recurrent. Carcinosarcoma was again included in this population as well. Moving to the primary endpoint and secondary endpoint, PFS, we can see that there is a clear separation of curve. We can see that at 18 months, there is a almost, increment by adding IO. And if you add further PARP inhibitors, there is a further increment from 21 to 37% and 37 to 46.3%. It is clearly shown that, incremental effects of addition of each drug. And if you look at the OS, that is secondary endpoint, we can again see that chemotherapy plus durva plus olaparib doing definitely better, and even chemo plus durva also doing better. And however, the separation of curve starts quite late beyond around 18 months. If you look at the median OS, it's not reached in the chemotherapy plus IO plus chemotherapy plus IO plus olaparib, as opposed to chemotherapy alone arm, which median OS was 25 months. And if you look at the hazard ratio, it is statistically significant in chemo plus durva plus olaparib as opposed to chemotherapy alone, with a hazard ratio of 0.59, that is 41% reduction in having a mortality event. So it showed a clinically meaningful benefit. And if you look at the particularly deficient MMR, the gray line is the clear chemotherapy arm, and the other two, IO plus olaparib and IO alone arm, are way above the chemotherapy curve. And there is a dramatic improvement in the PFS benefit. And it was roughly around median PFS was 7 months, and which was not reached in the chemo plus IO arm, and 31 months, almost 4 times the tough chemotherapy in terms of median PFS. If you look at proficient MMR, again, we can see the clear separation of all the 3 curves, which was discussed earlier. So if you look at the objective response rates, it was almost 15 similar in all the 3 subgroups. But if you look at the complete response and partial responses, they were high with the chemo and IO, chemo IO plus olaparib arm. And if you look at the median duration of response, again, it is much higher in the chemo plus IO, that is 10.6, and chemo plus IO plus olaparib has led to median duration of response of 18.7 months. So if you look at the OS by MMR status, definitely MMR deficient derived the maximum benefit. And even in the proficient MMR, we can see that towards the tail end of curve, there is a clear separation of curves. And in particularly in chemo plus durva plus olaparib arm, there is a clinically meaningful benefit in terms of OS as well. So if you look at PFS by PDL1 status, if they are PDL1 positive, there is a very clear separation of addition of each drug to chemotherapy. Addition of IO has led to improvement, and again addition of olaparib to the chemo plus IO has led to further improvement from 20 to 40%, and another 15% increment at 18 months, particularly if they are PDL1 by TAP score. And if they are PDL1 by TAP score less than 1%, the benefit is very, very small, and almost they are overlapping, curves are overlapping. Probably TAP score may become new standard of selection of patients in the endometrial cancer, particularly among MMR proficient subgroups. So if you look at the subgroup analysis across various subgroups, we tend to see, particularly among PDL1 scores, if it is PDL1 tap, it is crossing line of unity. And if it is more than 1%, definitely it is benefiting both in PFS as well as OFS. Coming to safety, there are no new concerns. It was similar to what was observed in other PARP trials and IO trials. And hematological toxicities were higher if you add a PARP inhibitors to chemo plus IO. So these are all the trials which looked at immunotherapy. We can clearly see that in deficient MMR, there is a huge benefit across all the subgroups. And in proficient MMR, there is a definitely benefit in the DuoE, Pembro and Ruby trial as well. So to conclude my talk, DuoE study met both primary endpoints. Both CP plus Durva as well as CP plus Durva plus olaparib demonstrated a significant improvement in PFS over standard of care. CP plus Durva also reduced risk of progression or death by 58% versus CP in the deficient MMR. The combination of CP plus Durva plus olaparib further improved outcomes in proficient MMR patient, demonstrating longest median PFS in the patient population with 15 months, and further improved outcomes in PDL1 population, PDL1 positive patients. And there were no new safety concerns in this trial. With this, I conclude my talk. And
Yeah, thank you, Dr. Shivasankar. I think it's upcoming competition.
Hi, sir. Good evening. Good evening, everyone. So I hope my slides are visible, sir.
Yeah,
Yes, sir.
good evening. Slides are visible.
Okay. So thank you at the outset for the opportunity. And I'll be discussing LCODC, the L journey. So if we see NSCLC paradigm, so almost half of them, they have the actionable mutations, out of which, if we particularly talk about ALK, so it is roughly said to be around 3.7% is the figure. And especially in Asian population, not with regards to L, EGFR we know is higher as compared to non-Asian population. Probably ALK incidence is similar. So there are a lot of targetable mutations: EGFR, ALK, BRAF, ROS, RET, MET, NTRK, HER2 mutations, and KRAS. 45% is the figure overall. So if we specifically talk about ALK, there are methods: IHC, FISH, PCR, and DNA RNA based NGS. So currently, we all know that probably DNA RNA NGS is preferred. IHC is a cheaper method and cost effective, and it can give results in a day or two. But many times there is limitation with regards to the amount of tissue. So most of us, I think, we prefer to go for NGS panel along with the PDL1 at the outset, rather than doing IHCs first, followed by other tests. And if we see ALK inhibitor development timeline, so we all know first generation ALK inhibitor discovery of ALK was in 2007. Then was the era of crizotinib, the profile trial, and then ceritinib and the second generation inhibitors, alectinib, brigatinib, and then later on 2019, lorlatinib came into picture, and slowly the longer follow-up data is coming, and now it's being approved for the first line. So we'll see that data. Why there was an unmet need in the ALK? So usually these patients, they are younger and they are non-smokers or light smokers. If we see CNS involvement, so at baseline, around 20 to 30% patients, they have CNS involvement, and with treatment over a period of time, additional 20% patients, they develop CNS disease. So there was an unmet need of better targetable therapy in this particular setup. And there are challenges with second generation TKIs, including rapid development of resistance and limited CNS penetration, duration of control, particularly in those patients who have brain metastasis. So there was a need for additional TKI which can prevent emergence of resistance, as well as that can have better brain penetration and better durability. And also, it was important that effective TKI should be tested in earlier lines, because we always know that approximately 1/3 patient, they drop out for the next line of treatment. This is not regarding this is regarding any other targetable or any other therapy, especially in metastatic setting. So if you see data, especially in ALK positive, so around 1/3 patient or 20 to 30% of the number, where irrespective of the line of treatment they have received, next line one-third of patients, they will not come for treatment. So those patients who have received chemotherapy, almost 30% will never come for next line of treatment. And similarly, those patients who have received first or second generation ALK inhibitor, almost one-third, they will be lost to follow-up or they will not come for the next line of treatment. This is a real-world data from WCLC 2024, almost 1,000 patients. And they have shown that around 30% of ALK positive patients, they have baseline brain metastasis, and additional 20%, they develop brain metastasis while they are on second generation ALK inhibitors. So there are different endpoints, and each of them have their importance, including overall survival, CNS efficacy, PFS, response rates, and next line of treatment. So for deciding the first line or upfront therapy for metastatic ALK positive patients. So we all know the data, and again, we'll see a review snapshot of this landmark trial. It had included mainly stage 4 patients and some patients with stage 3B3 also. So locally advanced and metastatic ALK positive, and we all know they have included asymptomatic or previously treated but stable brain metastasis. They were randomized 296 patients in 1:1 patient between lorlatinib 100 mg and crizotinib 200 mg BD doses. And primary endpoint was PFS, and secondary endpoints were overall survival, PFS by investigator, and response rates and safety and quality of life endpoints. And at 18 months, first interim analysis was planned, and subsequent post-hoc analysis was planned at later time points. So until last year, we have seen that investigator-assessed PFS was not reached at 3 months, at 3 years, while in Alex and Alta trial, it was less than that. So specifically in Alex trial, in investigator-assessed PFS, it was 34 months, and in DICR-assessed PFS endpoint, it was 25 months. So around 2 to 3 years, if we take both of them, 2 years BICR and 3 years approximate is investigator-assessed PFS in Alex. While similar is the case scenario in Alta, 24 months and 30 months in BICR and investigator-assessed. Sorry. While if you see ground data, both of them at 3 year time points were not reached, with hazard ratio being 0.27, 0.1. Then later on, 5-year data came, and sorry. So at 5-year time point, 60% of the patient in alectinib arm, they were disease free, as opposed to 8% in the crizotinib arm. So hazard ratio was very good, 0.19. And if you see PFS analysis by investigator assessing patients with and without brain mets, so the quantum of benefit appears to be similar whether there is brain met or not. Sorry. Although those patients who had baseline brain met, they did very poor in crizotinib arm. As we know, this TK does not have brain penetration. And if you see particularly data from Asian subgroup, again, so 63% versus 7% is the data, again favoring the lorlatinib. And across the subgroups, whether there is brain mets or not, ethnicity, Asian versus non-Asian, gender, age, and smoking status, so all of them, they were benefited. And as if you see cross comparison, so as compared to Alex data, hazard ratio were much better in ground. Then again, similar thing. So if you see first generation TKIs, then probably the median PFS is doubled as compared to chemotherapy. And if you see second generation TKIs, probably the response rates and PFS are better, and PFS is doubled as compared to first generation. And with this third generation lorlatinib, probably PFS is way more than doubled as compared to first generation. So there is always a PFS OS debate whether we should still wait for the OS data to mature, for the events to happen, to think whether there is really a benefit. But if we see 5 years data of LX and Alta trial, so they had approx 60 to 62% of 5 years OS data, while alectinib while lorlatinib still has PFS rates of 60%. So thereby, we can say probably that the PFS of lorlatinib is almost equal to OS of second generation TKI. So definitely it is going to achieve advantage. And if we see the earlier phase 1-2 data, which has already median follow-up of 72 months. So at 5 years, their OS was 76%. It was a single arm study. And if we see the data in LX and Delta, so 5-year OS 62%, in LX and Delta is 66%. So similar thing. So it is the PFS in the ground trial. And obviously more than half of the death events has to happen to trigger the release of OS data, and 50% patients are still disease-free or progression-free at 5 years time points. So at this rate, if we calculate that, probably OS or even PFS will reach at 9 years. If we see time to intracranial progression, again, we know that this molecule has way better vein penetration, so it is much better. We see the hazard ratio for this, it is 0.06. So we should mind that this is not p-value, this is hazard ratio, 0.06. Similarly, time to intracranial progression was longer in lorlatinib, whether there were presence or absence of brain mets at the time of baseline. And again, if we see complete intracranial responses, then they were better in lorlatinib, 58% as compared to second generation TKIs. And similar is the case if we see the overall intracranial responses. We see specific subgroups. So we know variant 3 has poor prognosis, but if you see the data of alectinib in variant 3, so 60 versus 5.6 months again. So similar is the benefit irrespective of variant, whether it is variant 1 or variant 3. And in case of TP53 also, so we know that co-mutation of TP53 portends poorer outcomes in ALK. So data with crizotinib tells probably that TP53 mutated population has 5.7 months PFS as compared to 9 months in those who have wild type. But in lorlatinib, again, PP53 mutated also had around 51 months of PFS. So again, it is better. And if we see the second generation TKI trial, so in PP53, Alta trial had around 1.5 months of PFS. So again, lorlatinib appears to do way better than any other TKI. With regards to safety and management, so overall, it appears to do similar as compared to any other TKIs, and 11% is the figure where they have to do permanent discontinuation of lorlatinib. And if we see other TKIs, so except for ceritinib, I would say data for permanent discontinuation and of grade 3 toxicity is almost same. And ceritinib appears to be the safest, only 5% permanent discontinuation, while rest all TKIs around have around 10 to 12% discontinuation. With regards to toxicity, we all know that hypertriglyceridemia, hypercholesterolemia, weight gain, and hypertension are the, and edema also are the commonest side effect with this molecule. This is the time to onset and duration of important side effects of lorlatinib. Probably first side effect to start is the derangement of biochemical parameter or metabolic parameter, that is hyperlipidemia. It starts by day 15, and then later on cognitive changes, mood effects, edema, peripheral neuropathy, weight gain, and cognitive effect, they tend to appear. So almost 70% of the patient, they experience hypercholesterolemia, and 2/3 of the patient, they experience hypertriglyceridemia. However, only 1% patient, they had to discontinue lorlatinib due to hyperlipidemia. And with respect to CNS effect also, so almost 40 to 42% patient, they develop some sort of adverse event, and 2% patient only they had to discontinue due to CNS adverse event. And around 57% patient experience weight gain, and 44% they experience 57% patient they experience edema, and 44% they experience weight gain. However, no patient discontinued in this trial because of edema or weight gain.
Sir,
And
sorry for intervening. Need to conclude, please, sir.
okay, so I would say most of these side effects, these are manageable with dose interruptions or sometimes dose reduction also, and then we are able to resume therapy in most of the patient probably with dose reductions. And these are the guidelines for management of side effects. And this is real world data which was presented in ASCO 25, around 50 patient data from India, and they have also reported 10% discontinuation rates and similar response rates, 74% and intracranial response rates. So this is my last slide. So lorlatinib is now standard of care because we know if we sequence, then probably benefit is less, and versus if we start TKI at the upfront, then PFS benefit is way better. Thank you.
Yeah, thank you, Dr. Ashutosh. And over the years, we have learned that definitely lorlatinib, the quantum of benefit with lorlatinib in the ALK space is the maximum. And we have also seen that using it in the earlier lines is most effective as compared to using in the later lines to use the best drug upfront. Previously, there were a lot of concerns about the toxicity, but as we have used this drug more and more, we have come to know that yes, these toxicities are manageable and not going to uh, happen any in the quality of life of the patient won't be hampered. So I think with that, lorlatinib has taken that space that it is now the drug to go for the ALK space. So thank you once again. And from metastatic, we'll now move on and shift our gears to the neoadjuvant setting in the targeted arena. And we have for that we have the first-in-class trial, that is the NeuroAdora trial, which is the use of osimertinib along with or without chemotherapy versus chemotherapy in EGFR mutated non-small cell lung cancer. And for this, we have with us Dr. Sahil Bambru. He is a senior consultant in Department of Medical Oncology at BLK Max Super Specialty Hospital, Delhi. Over to you, Dr. Sahil.
Hi, good evening. Thanks a lot for the invite and for the opportunity. And we'll be talking, and I'll not take much time, I'll keep it short. We'll be talking about the NeoAdora trial. This is a trial which talks about neoadjuvant osimertinib with or without chemotherapy versus chemotherapy alone in the resectable EGFR mutated lung cancers. Next slide, please. Next slide, please. Yeah. Now, as we all know, neoadjuvant chemotherapy and chemoimmunotherapy are options for resectable NSCLC. However, major pathological rates with neoadjuvant chemotherapy and chemoimmunotherapy are quite low, 0 to 8% in EGFR mutated non-small cell lung cancers. Most effective neoadjuvant treatment enables patients to complete surgery and derive survival benefit of adjuvant osimertinib as demonstrated in ADORA trials. And what would be the advantage of effective neoadjuvant therapy? It would be reducing disease progression, precluding surgery, improving surgical outcomes, and improving the long-term treatment outcomes. Now, as we know that we have been using osimertinib in the adjuvant setting for our early lung cancers post-surgery. So extrapolating that and then seeing how it responds, keeping in light the benefits of neoadjuvant injectinib on even the OS, this is a step ahead from that. Next slide, please. Now, how exactly has this trial been designed? This basically has taken eligible patients aged 18 years and older with a good performance status with histologically or cytologically documented non-small cell lung cancer considered to be completely resectable. The EGFR exon 19 deletions or exon 21 deletions mutations were confirmed, and these patients were basically assigned 1:1:1 to oral osimertinib once a day for more than 9 weeks, plus platinum-based chemotherapy once every 3 weeks, 3 cycles. The second group had oral osimertinib 80 milligram once a day for more than 9 weeks as monotherapy, and the third group had an oral placebo once daily for more than 9 weeks with platinum-based chemotherapy once every 3 weeks for 3 cycles. The chemotherapy used were pemetrexed with investigators' choice of carboplatin or cisplatin administered according to the local practice, and osimertinib and placebo were administered in a double-blinded fashion. So next slide, please. Now, as we can see, the distribution between the groups of 121, 117, and 120 patients was quite comparable. Next slide. And the good part about this particular intervention in the neoadjuvant setting was that, as we can see, 92%, 97%, and 89% respectively of the osimertinib chemotherapy, osimertinib monotherapy, and chemotherapy alone were actually able to undergo surgery, as compared to around 80% patients only in the chemoimmunotherapy trials, wherein we know that around 20% patients, who are upfront resectable, become unresectable after chemoimmunotherapy. So that's a good and an encouraging part that we've seen. And all our patients who underwent surgery, more than 90% in every arm, have been able to undergo an R0 resection. Next slide, please. Now, fewer patients had progressive disease, precluding definitive surgery with both the osimertinib containing regimens, and that is something which is encouraging. Next slide. Now, the major pathological response rate was significantly higher with both the osimertinib containing regimens. So, in the osimertinib and chemotherapy regimen, we've seen 26% of major pathological response and 25% major pathological response in the osimertinib alone arm, and only 2% major pathological response has been seen in the chemotherapy alone arm. Now, major pathological response is basically pathological complete remission and less than 10% of viable tumor cells at the time of resection. So that is what is defined as the major pathological response. And if we can basically see, shown a subgroup analysis. Next slide, please. So if we can see this slide, it's pretty important to see this slide. Now, if you can see the pathological complete remission here, it is only 4% in the osimertinib chemotherapy arm and 9% in the osimertinib alone arm. That we can, not even 2% in the chemotherapy alone arm that we are seeing. So whether or not we can take major pathological response alone as a proxy or a very great prognostic indicator remains to be seen, because I'm not sure whether we can take major pathological response alone as a proxy for pathological complete remission. Although we do have trials where in the chemoimmunotherapy trials, they've actually seen that pathological complete remission and your major pathological response have shown event-free survival and OS benefits, but I'm not sure whether that can be replicated and compared to the targeted agents in this particular setting also. So that is something that remains to be seen, because the data is still immature and long-term follow-ups would be required to see the long-term benefit with this intervention. Next slide. So nodal downstaging is another aspect that is quite important in the osimertinib chemotherapy arm. We have seen 53% patients with a baseline N2 disease were downstaged at surgery, and 53% again in the osimertinib monotherapy arm also have shown a downstaging of disease, as compared to only 21% in the chemotherapy alone arm. However, this data also needs to be taken with a pinch of salt, because regarding the nodal downstaging, not really commented many patients have actually been analyzed in this particular subset analysis, because this data was available for less than 50 patients from each of the treatment arms, and the authors have not reported on the nodal clearance, which is clearly linked with long-term survival in stage 3 NSCLC. So since we don't have those details, and since data of very few patients here has been seen, as we can see, so that's why, as you can see the N also here, it's only for 47, 38, and 34 patients. So that's why I'm not sure how much we can comment on this slide. However, if at all there is nodal downstaging, and if we see it in real world studies later on also, it was definitely going to help us in clearance also. Next slide. So the interim event-free survival analysis with 15% majority does show benefits here, this is 93% as compared to 83% at 1 year, and this needs to be followed up. So this is certainly something encouraging. Next slide. And interim EFS by MPR status is also something where more data basically needs to be followed up, and it is encouraging and it is showing benefit even with this subset. Next slide, please. So considering the safety profile, we actually don't have any safety alarms here in any of the segments, and most of these drugs are pretty well tolerated, and the regimens have been quite okay, other than few discontinuations from therapy that have happened, mainly in that we've seen. Next slide. So safety findings were consistent with the known profiles of the individual agents, and there have not been any major discontinuation. As we have previously pointed out, most of the patients who were planned for surgery did indeed undergo surgery more frequently than we have seen in the chemoimmunotherapy trials. Next.
Thank you, Dr. Sail. I think neoadjuvant osimertinib with or without chemotherapy has definitely demonstrated a significant improvement in the major pathological response rates
Yes.
over chemotherapy alone. But we need to have long-term
More data.
more data, and even in terms of responses to see and to bring it to as a standard of care. So anyway, it's a very important data, and we'll be looking forward for the update on this. Moving on, we have now next study in the that is the IM fort in the small cell lung cancer. And this also is a very important update because over many decades we did not have the significant advances in small cell lung cancers. So this is one of the unique studies, that is the IM fort study. And to present this, I have my dear colleague, Dr. Abhishek Charan, who is a senior consultant in medical oncology at SCG Cancer Hospital, Jaipur. Over to you, Dr. Abhishek.
Good evening, sir. Thank you for having me today for this wonderful discussion and the meeting. So, can we have slide, please? Yeah. So, as sir already mentioned, this is one of the landmark study which has come in small cell lung cancer. As we all know, lurbinectedin is one of the agent which is a product or of tabernectedin, and it has been studied in small cell lung cancer in metastatic setting on multiple lines. Now it has been. Now it has been. Am I audible?
Yes, Dr. Abhishek, you're audible.
Okay, thank you. Thank you. So in the yeah, can we move to the next slide? So this agent has been extensively studied. Now it has been combined with atezolizumab in this study to see whether it will work as a maintenance or also or not. So what are the takeaways for this study? So IM4 is one of the study which has showed a meaningful PFS and OS benefit if it is combined as lurbinectedin plus atezolizumab as a maintenance in extensive stage small cell lung cancer. The safety profile is a bit issue, but as we can see in this study, their side effects were more, but most of the side effects were grade 3 and they are manageable. The combination of this atezolizumab has become a new standard in the first line treatment of extensive stage small cell lung cancer. Next, please. So the background, as we all know, small cell lung cancer is a very bad disease, though it is very chemo and radio sensitive, but patient will have very short, DFS, and they will progress very fast. So most of the patient will respond initially, 60 to 70% patient will respond for a brief period, and then eventually they will progress. And in my clinical practice, I have not seen any patient going for third line. They'll last up to only 2 lines, but others can put light on this. Ankit sir, would you like to comment on that?
Yeah, I agree. I think almost 50% of the patient don't even reach to second line, and third line also it's very rare to see.
Yeah. So as the data is there, only 60% of the patient will have response upfront, and then eventually they will progress. So what is this agent lurbinectedin? It is a alkylating chemotherapy agent, which is a transcription inhibitor, and that is approved by US and FDA and other agencies for a study in small cell lung cancer in metastatic settings post progression on platinum. So in preclinical trial, it has been also studied that if it is combined with immune checkpoint inhibitor, it may also give us high rate of overall response, and that is because of the it has an impact on the your T cell memory. So in the phase 1 and 2, it was studied and it was combined with ICI, and it showed a good promising result. So that formed the basis of using it in metastatic as well as uh, maintenance therapy also as a maintenance. So this trial, which is a phase 3 randomized trial, was conducted, and where they compared after giving first induction chemotherapy along with the IO, and in maintenance whether to give atezolizumab alone or if it atezolizumab combined with lurbinectedin. Next, please. So, as I already mentioned, the eligibility criteria, first patient was screened, they should have the extensive stage that, and they should not have any upfront CNS disease. Performance status ECOG 0 or 1, and they were initially given in all patients. I mean, they were given induction chemo along with the atezolizumab, and post that they were assessed for after 4 cycles. They were assessed for the response. When they had a good response, either it was CR or PR, even of stable disease, post induction chemotherapy, then they were randomized in two arms, either with lurbinectedin with atezolizumab or atezolizumab alone, and it was continued till either progression or unacceptable toxicity, and no crossover was allowed during that. Follow-up period was also studied in this case, which was mainly around 5 to 6 months, starting from the randomization after your induction chemotherapy. Next, please. So main primary our objective primary concern was in OS and PFS. So to reach to the significant OS in this, so they targeted HR hazard ratio as 0.71 to get the power of 85%. So interim analysis occurred when 219 death occurred, and if OS result was statistically significant at the interim analysis, they would constitute the primary analysis. Same was in PFS, no interim analysis was done. Primary analysis was conducted at the time of OS interim analysis only. Next, please. So these are the baseline characteristic. Most of the characteristic are more or less similar in both arms. As we can see, median age is around 65, 60% constituted male. Most of the patient, 80% were white race, and tobacco smoker, 97% patients were there in both arms. They had interesting data of liver metastasis was present at the baseline, which was around 40%. PCI formed a only marginal role. 15% patient had PCI before this, and ECOG status was good. 40 to 40, 50% was there. Most of the characteristics were similar. They also included LDH to see whether the disease load as per how much is there, and 72% patient and 74 in the other standard care were had similar. LDH was normal, and response to the induction chemotherapy initially was also similar. Overall response rate was around 87% in the experimental arm as compared to 88 in the standard of care. Next, please. So IRF PFS was assessed from randomization into maintenance phase, and as we can see in this graph, that at 6 months there is a significant difference in the PFS at this point, 41.2 versus 18.7. And if we convert it into months, so median PFS was 5.4 in the experimental as compared to 2.1. So it is significant of 3.3 month gain, and hazard ratio was also significant. I mean, it was 0.54. P value was significant. So this form a basis that it is a beneficiary agent. Next, please. So this is forest analysis. The as we can see, diamond is in the experimental arm side. All the subgroup analysis showed that it is beneficial either in all race, age, sex, tobacco, and liver metastasis, whatever subgroup, all had a good result if we combine lurbinectedin with atezolizumab as compared to standard of care. Next, please. So coming to the main thing, that is OS for us. So OS in the experimental versus standard of care at 12 month, it was 56.3 and 44.1. We can see the graph, they are widened up at least till 18 to 19 months, then they are flattening up, and then they are, because of the episodes and the events happening. So till 18 months, there is a separation of graph here, and it is quite good to see. And in terms of the median OS, it was 13.2 in the lurbinectedin arm, along with atezolizumab, as compared to 10.6 in the standard of care, that is atezolizumab. So hazard ratio was significant, 0.73, p-value was significant, and this showed a good result that 27% patient will have a better outcome in this. Next, please. So as we OS from randomization into maintenance phase, so induction treatment lasted, I mean, it included 3.2 months. So after that maintenance, if we randomize it to lubri plus atezolizumab, which constituted around 13.2 months, as compared to atezolizumab, 10.6 months. So 2.6 month benefit was seen in this arm. Next, please. OS subgroup analysis was done, which showed that most of the subgroup had a better result in case of lurbinectedin. We can see in the age also, sex, race, tobacco, liver metastasis, prior PCI, ECOG status, all constituted a better result. Even the confidence interval is also more, most of them are towards the one side only. Next, please. So confirm IRF assessed overall response rate and duration of response. These were secondary endpoints, and even that showed a good result. So overall response rate was 19.4% in case of lurbinectedin atezolizumab, as compared to 10% in atezolizumab. So there is a difference in overall response. So even follow-up systemic anti-cancer treatment, patients were given second line, and the follow-up, I mean, discontinuation rate and the agent which were given. So most of the patients were able to receive further lines if they were in lurbinectedin atezolizumab as compared to atezolizumab. And so this is also an interesting point. Next. So coming to the main problem in this trial, what I felt was that side effect due to lurbinectedin were quite high. Though I have not given it personally to any patient as of now, I'm not aware about it. But as per the data suggests, it has a more grade 3 and grade 4 side effects. It constitute almost 97% patient had side effects, out of which 38 had grade 3 to 4 in this arm, as compared to the 22% in the standard of care arm. Even the side effects, grade 5 adverse effect were seen, that was 12 in absolute number in lurbinectedin atezolizumab as compared to 6 only. That is, so side effect are almost double in case of lurbinectedin atezolizumab as compared to your standard of care.
I think we have lost Dr. Abhishek, but he has already, I think, reached to the conclusion. So definitely, it was one of the strategies which is being evaluated and have shown OS benefit. But in terms of toxicity, which Dr. Abhishek was highlighting, is also very,
Yes,
very
sir, sir.
important.
Sorry, my network cut down, sir, because I was traveling. Sorry. So I
No,
was
no.
just in my end slide to conclude it that it's a good study, but side effect profile may be a limiting factor to use it widely. I don't know about the availability and cost part. So as per the data suggests, side effect may play a role in using it properly. We may have to reduce the dose, and the continuation may be issue. But other than that, it shows it is a promising. Sir, over to you.
And I think by the time it will be available and ready to use and accessible in India, by the time we'll have a long-term follow-up as well. Yeah.
So
Yes,
thank you, Dr. Abhishek. It was very important study. And moving forward, we have another important abstract that is about the use of neoadjuvant nivolumab along with chemotherapy. That is the Checkmate 816 phase 3 study and in resectable non-small cell lung cancers. So for this, we have with us Dr. Rajiv Seni. He is a senior consultant in medical oncology at Vaishno Devi Narayana Super Specialty Hospital, Jammu. So, Dr. Rajiv, over to you.
Thank you, Dr. Ankit. Thank you for inviting me. As we know that this drug in this setting has been approved in 2022. At that time, we have only significant EFS benefit, but the OS data was immature. Now they have presented overall survival data, 5-year analysis. Next slide. So in this pre-planned final analysis, they have shown that neoadjuvant Nivo plus chemo demonstrated a statistically significant and clinically meaningful OS benefit versus chemo. And it has already shown durable long-term EFS benefit. Patient with pathological complete response following neoadjuvant Nivo plus chemo had improved long-term OS compared with those who are without PCR. And another exploratory analysis they have done with ctDNA. They have shown that if there was clearance of ctDNA pre-surgically, it was also associated with improved OS regardless of treatment. Next slide. In this phase 3 trial, Nivo plus chemo demonstrated statistically significant and clinically meaningful improvement in EFS and PCR versus chemo in patients with resectable non-small cell lung cancer with EFS hazard ratio is 0.63 and PCR rate is 24% versus 2.2. So this is the sole neoadjuvant only chemoimmunotherapy regime, which was approved in the United States, European Union, and several other countries. And now we present here the pre-planned final analysis of OS from Checkmate 816 at a minimum 5-year follow-up. Next slide. So you all are very well aware of this trial design. They have included patient of stage 1B and in 1B only those patients where the T is more than 4 centimeter, up to stage 3A non-small cell lung cancer with performance state of 0 to 1 without any actionable mutations. And they have stratified by stage 1B, 2 versus 3A, PDL1 more than 1 versus less than 1, and gender. They have given Nivo plus chemo for 3 cycle versus chemo alone 3 cycle. Then they have again restaged radiologically and patient underwent surgery within 6 weeks. After that, patient were follow up only depending upon the stage and pathological staging. Some patient may can receive adjuvant chemotherapy or radiotherapy depending upon the pathological stage. So their minimum follow-up is now more than 5 years. The primary endpoint was pathological complete response and event-free survival. Key secondary endpoints were overall survival, major pathological response, and time to distant metastasis, and exploratory analysis, that is OS by PCR and ctDNA clearance, and lung cancer specific survival. Next slide. They have very interesting statistical analysis plan. They have done hierarchical analysis. First, if the PCR and EFS were significant when tested by type 1 error, then only they have tested for EFS with two-sided type 1 error of 5%. And if PCR and EFS both were significant, then OS was to be tested hierarchically with two-sided type 1 error of 5%. Significance boundary was calculated by two-sided p-value of 0.0482 at the final database log. Next slide. So this was the final analysis of overall survival. From this graph, it was clear that median OS was not reached even after 5 years in Nivo arm versus 73 months in the chemo arm. And the p-value is 0.72. You can clearly see that at 5 years, 65% were alive in the immuno arm versus only 55%. So there is clear-cut difference of 10% at 5 years. Next slide. Regarding the subsequent therapy, 90% of the patient in chemo and 75% of the patient in Nivo arm received subsequent therapy. And out of this, 78% received systemic therapy and 58% in Nivo arm. And immunotherapy for 50% of the patient in chemo
who have received chemo subsequently received immunotherapy, while in Nivo plus chemo, they have again 54% patient received subsequent immunotherapy also. Next slide. Regarding the subgroup analysis, you can clearly see that the majority of the diamonds were on the Nivo side. And regarding stage 1B versus 3A, the patients with stage 3 both were benefited. However, stage 3A were benefited more as compared to stage 1B2. Similarly, the patient who are PDL1 positive, they were benefited more as compared to those patients who are PDL negative. Next slide. So in the patient who was stage 1B2, median OS was not reached versus 76.8 months. And in stage 3A, again, median OS was not reached versus 73.7 months. And in stage 1B2, the 5-year survival OS was 65% versus 60%, while in stage 3A, it is 65% versus 53%. So the quantum of benefit is more in stage 3A as compared to stage 1B or 2. Next slide. Again, similarly, if we stratified according to PDL1 status, the patient who are more than PDL1 more than 1%, the hazard ratio is 0.51 as compared to 0.89 in PDL1 less than 1%. Next slide. Regarding lung cancer specific survival also, the unstratified HR is 0.65. 75% of patients were alive without lung cancer as compared to 65% in chemo arm. Next slide. Event-free survival at 5 years, it is 49% at 5 years versus 34%. So again, the difference is 15%. Median EFS is 59.6 months in Nivo arm versus only 21 months. So there is almost tripling of the EFS. Next slide. And if we see by the PCR status, those patients who among patients with PCR, death occurred in 3 patients only. And among patients with no PCR, there were total 46.6% death as with, and out of which 33% were due to disease. Next slide. Again, EFS by PCR status. Again, those patients who have PCR, they have much better EFS as compared to those patients without PCR. Next slide. Again, among patients with detectable ctDNA levels at cycle 1, 56% patient in immuno arm versus 35% in chemo arm had ctDNA clearance. Next slide. Regarding safety summary, there was no additional side effect were seen in patients who underwent surgery because of the immunotherapy. Next slide. So in this pre-planned final 5-year analysis from Checkmate 816, neoadjuvant Nivo plus chemo demonstrated statistically significant and clinically meaningful OS benefit versus chemo with hazard ratio of 0.72. 5-year OS rate was 65% and 55% in the Nivo versus chemo alone arm. It improved lung cancer specific survival. Patient with PCR with neoadjuvant Nivo had 90% reduction in the risk of death by 5 years versus those without PCR. Pre-surgical ctDNA clearance was associated with long-term OS improvement. The safety profile was consistent with previous report, and this was the only phase 3 trial of neoadjuvant only chemotherapy, which has demonstrated a statistically significant OS benefit across any resectable solid tumor type, and a firm paradigm shift in the treatment of resectable non-small cell lung cancer without actionable genomic alterations. However, in this setting, we have perioperative options also available, and out of those perioperative options, the perioperative pembrolizumab also shown overall survival benefit, while perioperative again trial perioperative durvalumab has significant EFS and benefit, but not clearly statistically significant OS benefit. So this is all from my side. Thank you, and back to the organizers.
Thank you, Dr. Rajiv. Just a small clarification, although it's a very good update and we have now long-term data with the overall survival benefit as well. So there was no adjuvant treatment in this trial.
No. This basically in adjuvant treatment is only optional in this. If the patient has N2 disease, then radiation is to be added. And if the clinician feel that adjuvant chemo is to be given, then only. Otherwise, there is no adjuvant immunotherapy was given in this. As in other perioperative approach where adjuvant immunotherapy has continued for 1 year, in this no adjuvant immunotherapy was given. So if we
Yes.
see if we look at by the cost effective, so this option is very cost effective.
Yes, so that's what I was also wondering, that by giving only 3 cycles of immunotherapy, we are saving a lot of logistics and other cost issues. So, and there was no stratification based on targetable mutations like that also.
No, because they have excluded the patient who are EGFR or ALK mutated.
Okay. So, thank you once again, Dr. Rajiv. It was a wonderful presentation.
Thank you.
So moving on to our last talk of the day, but it is also very important, and we are juggling back to small cell carcinoma arena. So we have a Delphi 304 study, which is on the DLL3 target tarlatamab, and this is also one of the new drug which have come up in the small cell lung cancer arena. And for this, we have Dr. Neha Rawat. She is a senior consultant in medical oncology at Sant Tokba Dullabaji Memorial Hospital, Jaipur. Over to you, Dr. Neha.
Good evening, Dr. Ankit. Am I audible?
Yes, you are audible. Good evening.
Good evening. So thank you for having me today. Can you please share from your side, the organizing team?
Tech team, please, can you share the slides?
Or I should share?
They are sharing. Just a second.
Okay.
Can you make it full screen? Yeah, thank you.
Thank you. So as we know, in small cell lung cancer in second line, we do not have so many good options. So there's a new molecule tarlatamab that is introduced and trial done, phase 3 trial, Delphi 304 study. So this study compared tarlatamab versus chemotherapy second line in treatment for small cell lung cancer. Next slide. So the key takeaways. So the phase 3 Delphi 303 study, tarlatamab significantly improved overall survival and progression-free survival, reducing the risk of death by 40% compared with the chemotherapy. And when compared to the chemotherapy, it has significantly improved patient-reported outcomes of dyspnea and cough, and it has a lower rate of high-grade adverse events and lower rate of adverse events that lead to treatment discontinuation. And both the CRS and ICANS are mostly grade 1 and grade 2, and these are well manageable. So the Delphi 304 study affirms tarlatamab as a new standard of care in patients with previously treated small cell lung cancer. Next slide. So, the tarlatamab is a bispecific T cell engager immunotherapy that directs the cytotoxic T cells to the DLL3 expressing small cell lung cancer cells, resulting to the tumor cell lysis. So, it demonstrated the durable anti-cancer efficacy in patients with previously treated small cell lung cancer, and survival with current second-line chemotherapy option is modest, and it is also associated with substantial toxicities. So this study conducted to assess whether tarlatamab could improve the survival for patient with SCLC whose disease had progressed or recurred following one line of platinum-based chemotherapy. So the result of from the first planned interim analysis of phase 3 Delphi 304 trial comparing the tarlatamab to the chemotherapy for second line treatment of small cell lung cancer. Next slide. So it is a randomized controlled phase 3 study. The key inclusion criteria are the disease should be histologically or cytologically confirmed small cell lung cancer, progression after first line platinum based chemotherapy with or without PD-L1 inhibitors, and ECOG performance score 0 or 1, asymptomatic, treated or untreated brain mets are included. So the trial stratified the patients with prior PD-L1 expression, yes or expression present or not, chemotherapy free interval less than 90 days, 90 to 180 days or more than 180 days, and presence of brain mets and the type of chemotherapy. So randomization done 1:1 tarlatamab versus chemotherapy. The primary endpoint was overall survival and key secondary endpoint was PFS and patient-related outcomes. Next slide. So the baseline characteristics are well matched. Next slide. So the Delphi 304 met its primary endpoint with tarlatamab demonstrating superior overall survival over chemotherapy. The median overall survival with tarlatamab is 13.6 months versus chemotherapy 8.3 with hazard ratio 0.6. Next slide. So it showed the benefit with all the pre-specified patient subgroups, whether it is age, sex, race, and PDL1 expression, chemotherapy-free interval, presence of brain metastasis, liver metastasis, or use of type of chemotherapy. So in all the subgroups, it showed better outcomes. Next slide. So the PFS was significantly longer with tarlatamab versus chemotherapy. The tarlatamab arm, the median PFS is 14.2 months versus chemotherapy 3.7 months, and the hazard ratio is 0.71. Next. So objective response rate is better with tarlatamab, and the median duration of response 6.9 months with tarlatamab versus 5.5 with chemotherapy. Next slide. And tarlatamab improved the symptom of dyspnea and cough after 18 weeks. The chemotherapy worsened the dyspnea, whereas cough and chest pain improved with tarlatamab versus chemotherapy. Next. So tarlatamab also had a favorable safety profile, as all grade 3 side effects are mostly equal in both the arms, and grade 3 are more with chemotherapy arm. So next slide. And CRS and ICANS also mostly of grade 1 and grade 2, very less with grade 3 and serious events. So they are well manageable. Next slide. So patient treated with tarlatamab experienced a lower incidence of high grade side effects with tarlatamab. Next slide. So in conclusion, in the phase 3 Delphi 304 randomized control trial evaluated tarlatamab versus chemotherapy in patient with small cell lung cancer whose disease had progressed or recurred following one of platinum based chemotherapy with or without PDL1 inhibitors. And in this study, the tarlatamab treatment achieved 40% reduction in the risk of death compared to chemotherapy. Benefit extended to those with poor prognostic factors such as platinum resistance and brain metastasis. Tarlatamab improved patient-reported symptom of dyspnea and cough compared with chemotherapy, and it is a well-tolerated drug with lower incidence of high-grade adverse event and lower incidence of adverse events that led to treatment discontinuation, and CRS ICANS were mostly grade 1 and grade 2 in severity and generally manageable. So the superior survival outcome coupled with the favorable patient-reported outcomes and safety profile affirm the tarlatamab as standard of care for second-line treatment for SCLC. So the Delphi 304 study establishes a new paradigm for bispecific T-cell engager immunotherapy in the lung cancer. Next slide. So the article is published in NEJM. Next. The investigators were across the world. Next slide. Next. Next slide. So the lay summary of the Delphi 304 study was conducted to compare the how effective and safe tarlatamab was in comparison to the currently available chemotherapy drugs for SCLC that had not responded or had come back after initial treatment with chemotherapy. So we could get this drug as a better option in the second line. The patient given tarlatamab had 40% reduced risk of death, lived longer overall, and without their cancer growing or spreading, reported improved outcomes with cancer-related symptoms such as shortness of breath and cough. And the result of Delphi 304 study show that tarlatamab is more effective and safer than currently available chemotherapy options for recurrent SCLC. Thank you.
Thank you, Dr. Neha. Indeed, the small cell lung cancer was initially a biomarker-free cancer, but now with more and more precision oncology research and era, we have seen that DLL3 is one of the biomarkers which is there in small cell lung cancer. It is very highly expressed in the tumor and very limited expression in the normal tissue, so that makes it a more effective biomarker. And luckily, we
Yes.
have now ADCs and BiTEs against this, and also a lot of CAR T cell therapies are also being developed against this target. So it would be interesting to see moving on to into further next space and seeing this kind of drugs either in the sort of IM4 strategy which we have seen previous abstract in combination with immunotherapy, or in the first line in combination with the immunotherapy. So a lot of exciting times ahead. And with that, thank you once again for presenting this abstract and joining this webinar. With this, we conclude the second day of our OncoNext, the Future of Cancer Care webinar series. And I would like to thank all of those who have participated and presented in and helped each other in learning new points. And last but not the least, to thank our academic partners and pharma support teams. So they have come up, opened up, and supported us generously. So for the academic enrichment and further development, and so that all the benefit can be passed on to our patient in terms of better quality of life, survivals, and moving the oncology space to a better world. So with that, I would like to thank everyone, and good night, and Shabakh.
Thank you, sir. Thank you. Bye. Good night, sir.
Thank you.